Hello,
Yes, sir. Me,
what's your name?
Jignesh, sir.
जिग्नेश भाई जरा लाइव किया क्या आपने? या
Yes, sir.
या
है जात धर्म क्या सभी का ख्याल रखते हो। बस लक्ष्य है सेवा, सेवा से कभी ना थकते हो। नहीं जान की परवाह, निकले हो जान बचाने को। तुम रोक ही लोगे आंधी जो है आने को। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। कैसी ये जंग है, पड़ी मौत सांसों के पीछे। बने तुम जो मसीहा, जगी जिंदगी में उम्मीदें। वहाँ वीर खड़े हैं उन सरहदों की रक्षा में। यहाँ आप डटे हैं इंडिया की सुरक्षा में। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। शुक्रिया भारत के योद्धाओं, एमक्योर करे सलाम आपको। एमक्योर करे सलाम आपको।
very good afternoon, everyone. Satish, please share the CV slides. Very good evening, everyone. I am Dr. Ketan Kulkarni from Medical Services team at MQR Pharmaceuticals Limited. On behalf of MQR, I wish to welcome all of you to this webinar. Encure is a globally integrated company and 12th pharmaceutical company in India. It is also a research-driven company with 13 chirally pure molecules and 500 scientists working round the clock. Encure has 8 world-class facilities and 1 facility is in US. This is an initiative by Encure Pharmaceuticals in order to disseminate the latest happenings in the field of medicine through a series of webinars by eminent experts and renowned faculties from various fields. Today's webinar provides everyone an opportunity to learn and understand the recent advances in the field of orthopedics. We are really proud of you to be associated with this webinar. So, as uh, told earlier, our focus of this today's webinar is on orthopedics, and we have with us uh, the India's senior most and eminent orthopedic surgeon, Dr. D.D. Tanna. Dr. D.D. Tanna has retired from BIL Nair Hospital and TN Medical College, Mumbai, as from the Department of Orthopedics. He has 48 years of orthopedic experience. His special interests include revision, trauma surgery, and also joint replacements. He has been actively involved in teaching orthopedic surgeons all over the world and has delivered innumerable orations, guest lectures, and attended various prestigious meetings. He has also written chapters in textbook of orthopedics and also textbook in spine surgery. So we'll welcome Dr. T.D. Tanna, sir. Thank you very much for this webinar. Next slide, Mr. Satish. Yeah. We have a panel of experts, expert orthopedic surgeons today. So we have with us Dr. Sangeet Gawale, who is an MS in orthopedics, and he is a consultant orthopedic surgeon at Saifi Jaslok and Bhatia Hospital, Mumbai. At present, he is also the honorary professor at Grant Medical College at the JJ Group of Hospitals, Mumbai. Special interest of his includes complex trauma, joint replacement, and lumbar spine surgeries. He has facilitated many national conferences and lectures and also has many publications to his credit. Next slide. We have with us also eminent orthopedic surgeon who is joining us from Ahmedabad, Dr. Naveen Thakkar. He is attached to SAL Hospital, Sterling Hospital, Shalby Hospital, Sims Hospital, Nidhi Hospital, MediSurg, and many other hospitals. He has been awarded with Shushrut Award, IOCON 2006 at Delhi, and many more awards to his credit. He was the first orthopedic surgeon with US patents on flexible nail for fractures of long bone, and also has an international patent to his credit. Next slide, please. Dr. Asim Negi, he was earlier working in TN Medical College and Nair Hospital under Dr. Didi Tanna sir. And special interest of his includes complex trauma and spine surgery. He is currently practicing in Indore. So I welcome the faculty, and now I like to introduce Dr. Vasudev Gadegone. He is a president-elect Maharashtra Orthopedic Association, president of Vidarbha Orthopedic Society, president National Society of Interlocking Surgeons Association. He is also CCOT fellow and also Johnson & Johnson and IOA. Executive body member of Maharashtra Orthopedic Association and editor of Indian Journal of Orthopedics. Next slide. Yeah. So these were the eminent faculties, are the eminent faculties for today. We have a great pleasure of taking this webinar ahead with Dr. Didi Tanna sir. For the audience, I request you to please mute your mobiles and close your video so that sir can start the session. Over to you, Dr. Didi Tanna sir.
Hello, am I heard?
Yes, sir.
Yes.
Yeah. Friends, I think we'll be talking about the non-union. So I'll start with non-union related to nailing first, and then we'll talk about the plating. In between, we shall discuss the things. The four eminent faculties who are there, they will present the cases and we will discuss them. So after my first talk, we will be discussing the cases. My cases will be there in between, and we will just go on spending time in education that you will learn and I will also learn. Conventional definition of a non-union is when the fracture has stopped attempts at union and is not going to unite without surgery. This is how you and me have been talking about for years together. But today, modified definition is non-union is defined as a failure of fracture to unite, as evidenced by a lack of progression of the healing on radiographs and on clinical examination. Basically, if subsequent x-rays, after say 4 months is the time for the fracture to heal up. So 4 months x-ray and the 5 months x-ray, if there is no progression of healing, and 5 months x-ray and the 6 months x-ray, if there is no progression of healing, then conventionally, we would not still call it a non-union unless there is a sclerosis occurs. But this is the one in today's definition is accepted as a non-union which needs an action. So subsequent 2 months x-rays, if they do not show progress of the healing, then it is counted as a non-union. Now here in the good mode of healing, we all know there is an absolute stability and there is a relative stability while nailing and by a conventional plating, which we do it now with the small mobility which comes in nailing also, so that you get the callus formation. These are the two ways of healing which is occurring. Both ways are very important, all of us know. And if there is a stability, if it is 0 to 2 strain, Then there is a primary bone healing, which occurs in a compression plating or in a leg screw. If there is no callus there and in a leg screw compression fragment in neutralization plate, this is what is the healing which occurs. And a relative stability is when there is occurs in a good nailing and a plating with the long plating with the screws which are interspersed proximally. So 2 to 10% strain, relative stability, secondary bone healing, callus formation, bridge, buttress and tensionment plating, and also is more than 10% strain, fibrous union. And same applies to nailing. Even if the nailing doesn't give you this stability between 2 to 10%, then it will goes to fibrous union, as it is seen here. You can see here, this is not giving any stability. And that's the reason this has become instability of nailing. And that's why this has gone into non-union. So this is the nailing which is not advisable. And this is the one which you should not be doing it. And we will come to the situations how we can do a better nailing. Or here, is this the instability of the nailing? No, this is not the instability. This is too rigid a fixation, could not be dynamized because it was a static nail. So at the isthmus, it should be a dynamic nail all the time. Then it would heal up. I'll come to that in a short time. Nail gives a relative stability and so gives a callus formation. Too unstable doesn't unite. Addition of a multiple screws while locking in a different directions, proximally and distally, can improve the stability in an unstable situations after nailing. So unstable after nailing, just do not accept. Make it stable by additional measures. Like one and foremost is you do 2, 3, 4 screws in the locking screws, or you put in and you put in these 2 screws around the side, that is additional screws distally, which gives in increased stability because the nail doesn't swing around. Or you can put in like this 3 directional screws and you can increase the stability. Or fracture like this. At the end of the nailing, I felt this is not a stable construct. So I added up a plate. And that plate, you don't need a very big plate. You can put in these 3 half screws and these screws, and then you can see the whole thing has held up very well. Everything heals up. So you do not accept the unstable situations in a plating also, in a nailing also. In a plating, we don't accept. The same thing in a nailing, we don't accept. Now you can make it stable in a segmental fracture. There is intracortical screws if you put in. Then it can become stable. This is not a locking screw. This is the leg screw which has been put in, and you can see it has become stable. This is again a leg screw, and the whole thing is held up. So in a lower 1/3 fracture, this nail goes on swinging up and down on 2 sides. Because there is a junctional level, and you can see this is the level where it is not a stable construct. Distal femur is a poor site for antegrade nailing, as the hold of the nail in the distal fragment is poor. And you can see here in CT scan, the isthmus stops here and then it goes on expanding. So here the nail size is going to be only the thickest size, even if you put it, which is going to be in the isthmus, wherever it is. So when it comes distally, this is very unstable construct. So this is the one which is very, very notorious for non-union. So in a fracture like this, lower 1/3 and upper 1/3 junction, you've done the nailing and this is not united. 10 months it is not united. And so once it is not united, the surgeon tried to do the dynamization, which is not healing. The option is either you put in these multiple screws distally, if it is a lower 1/3 fracture, then it has a good chance of healing. Or here is the fracture. This is the nailing which was done. This is an antegrade nail. This is the nailing, as you can see, lower 1/3 junctional level. This is not going to happen. This is not going to work. 2 screws or 3 screws here is not going to work. So that's the reason why this is not ideal. So this is the one ultimately ended up into a non-union. Now, as I always call it, this is the joint replacement surgeon did it, because it is his case, he had done the TKR. So probably, unfortunately, he is not aware of the modern trends in trauma. Otherwise, this would not have happened by any of the trauma surgeons. So this is what happened. This went into a complete, because this is, you can see this is the instability and the hypertrophic callus which is formed. And as you can see, these two screws here lower down where there is the expansion of the distal femur which has occurred. So this can be easily treated by a long screw plate with the bone grafting. And this is the one which heals up very well. This is 1.5 years. It heals up very well. So this is what is the stability as to major things. So with nailing, if you don't get a stable, this, supposing if I had operated upon on day one, if I had done the nailing, I'm sure any one of you, Dr. Sanjit, you would add up a plate here if you've done the nailing in order to stabilize this. You are muted. You have to unmute.
Either that, a derotation plate or polar screws, and make the nail as distal as possible. So these are the alternatives.
Yeah. And here in this one, because of the nail, because of the joint, the nail also cannot go very much distally. So that is the reason why this is probably not the ideal construct. If any one of you want to add up something, you are most welcome at any time. Please stop me,
sir.
there is no hesitation. Now here is the second one, the ideal situation. Same lower 1/3 femur. You do a distal femur nail. Now distal femur nail becomes very stable because of this one screw and one spiral blade. And the major thing is, it is becoming it is subchondral. So when it is subchondral, that itself gives you excellent stability. When it is subchondral, it gives you excellent stability. And you can see it is held up. So this is a subchondral screw, which gives you the best stability here. These 2, 3, 4 screws, I think this will compensate for everything. So subchondral screw, when you do that, you do a distal femur nail, subchondral fixation which is there, and this addition of a spiral blade and a screw, this has given rise to excellent healing. And that's the reason why, while in a fracture like this is not a good situation. So the surgeon did dynamization, and dynamization also will not work. So ultimately, if you have to treat this non-union, this is the way in which I treat it. I retain the nail. I remove the locking screws. I put in the plate. I compressed it, whatever it is, and I put in a medial graft. So once this medial graft is put, you can see the whole thing is completely held up. I had removed the screw, the locking screws distally, compressed it for whatever it can be done. And you can see this is only 3 screws here, 1 screw here, and 2 screws here. You don't need a very, very rigid fixation there. Addition of a plate adds up the stability, and you will get a good healing here. And this is what I do it for a medial grafting. I open it up, seeing it on the X-ray, right onto the medial border of the bone. And as it is seen here, you go to the quadriceps, and then you do the shingling. And after shingling, you put in the graft there. And so here it is, the plate which has been put in a mid-po position without opening the fractures or anything. And this is all what it needed. You don't need anything to be done onto the, you don't have to remove the nail or anything. So here it is again, this is another case, non-union, supplementary plate, and this heals up. So at this level, the exchange nailing is also not certain. The distance stabilization is the thing. So I think the people do, if it is not healing up, you do dynamization. If it is not healing up, you do exchange nailing. You must understand where the dynamization will work, where the exchange nailing will work. Dynamization and exchange nailing are meant to be for a diaphyseal fracture. At the isthmus level, where the stability is good, and where you allow it to dynamize, it will heal up. Same thing is exchange nailing, you have not allowed it to dynamize. You have made a rigid fixation, and that's the reason it is not healed up. So if you have made it dynamic fixation on day one, it would have healed up. You need improved stabilizer, so supplementary plate is better, and grafting not to take any chance. This is what was done, and this is what is held up. Exchange nailing mainly at the isthmus, when the primary surgery was too rigid a fixation. Now I am coming to too rigid a fixation. Nailing, you cannot make it a too rigid, but if it is slightly distracted out or it is not allowed to collapse, then this is what will happen. I'll come to that now. Here is the peculiar situation. This was a static nailing, At the right at the isthmus where there is a good proximally and distally 1.5 to 2 inch of thing is there. And all what you need is the dynamic, change it to a dynamic nailing. And once it is dynamic nailing is done, it just heals up. So this is the ideal exchange nailing. Here you don't need even a supplementary plate and all, because this is at a level where the whole isthmus is there, where it is holding the nail proximally and distally. Now in distal 1/3, the hold is very poor. As you can see, the medullary cavity is increasing. This is what we have come in tibia also the same thing, in femur also the same thing. And particularly oblique fracture in tibia. This is a very unstable fracture. And so if you've done the nailing here, and surgeon did dynamization, and this is not going to work. This has become far too unstable. And this is ultimately, it goes away. The forces which are acting, this is going to be, here is the second case where the auto-dynamization occurs. And this oblique case into these situations, so this also comes out. So this is the one where it is, the auto-dynamization, this posterior screw is difficult, but then it can be treated very well with the rigid fixation with the plating and bone grafting. Bone grafting, whether it's needed or no, is a debatable issue. But as I said, if I'm doing the surgery, I'll do everything to get the healing. So this is what is done. So it is much easier to treat it at this junctional level. So here is again a junctional level with oblique fracture, which is treated with the leg screw. This is the one which is oblique fracture, which is plating, which is done. This is not going to survive. So it is a leg screw which is done, and then everything heals up. Now here it is, this is a comminuted fracture. All what you needed is first few leg screws here, and even a thin plate you can see with few screws, it heals up. Because the leg screws make the whole difference. So you don't have to do the nailing or everywhere. This is the one which can be treated with nailing. It can be treated with plating. It is all your choice, because the fracture is going right lower down here. And that's the reason I chose the plating here. But otherwise, even this, somebody wants to treat it with nailing, is perfectly all right. Probably Dr. Kadigune, you will treat this with nailing?
I always do with the nailing.
Yeah, because this is, as I said, with the good nailing, this should heal up. There is no issue about it. So if you are comfortable with nailing into this situation, you must do the nailing. It is a much better operation, than these leg screws and everything. While in a lower 1/3 tibia here, you must fix up the fibula. Once you do the nailing, you fix up the fibula. It improves the structure. And this ultimately, this is to be as low as possible. In order to put as low as possible, the reaming has to be done right all the way down. So the beaded guide wire needs to be changed to a non-beaded guide wire in order to go more distally. And then only you'll be able to do it. So this is what ultimately, it just heals up. This is healed up because I think the nailing is an excellent operation. So if you do the nailing in a distal 1/3 tibia, fibula plating is mandatory. Particularly the fracture is at the same level. Even some of the people may not agree to this, but this is what I feel is the safer situation. Now here it is, as you can see, the fibula is not fixed, and the nailing which is done, it is held up, but then the nail is moved, and here it is the dynamization date. So this is the bad healing with the angulation which is occurred. This is what it has to be avoided. You cannot accept this angulation because this is going to go on for a osteoarthritis in future. So this is the one which is not desirable. For a lower 1/3, I used to believe that the dynamization does not work. But I think Dr. Kadigune has beautifully shown that even in lower 1/3, if the dynamization does do a good healing, if there is a fibula plate there or not there. Yes, Dr. Kadigune.
Yes, sir.
Can you expand on that, please?
Hello.
Can you expand on nailing?
That nailing, sir, actually, this is the dynamization work even in a distal nailing if there is some bone callus formation around this. What you need is the only axial compression, which is provided by the dynamization, and majority of the cases they heals by dynamization if there is adequate stability there.
Yes, Sangeet, you want to add up something?
But at the same time, there should be some space distally to get the dynamize.
Yeah.
That
yeah.
is
That will
But
come
if you are
back,
going
yeah.
in a distal fracture, you are going subchondral, then there won't be any space.
Space, yeah.
That is the only thing you have to take care of.
Yes, Dr. Sangeet, you wanted to add up something?
Sir, you have shown 2-3 examples where there is an angular deformity developed following a nailing in the distal femur, in the distal tibia. Now, this angular deformity, it is a translation of the distal tibia or the distal femur because the screws are in the same direction.
Yeah, yeah.
So if you add up one screw, provided the nail is subchondral or about a centimeter, 2 centimeters above the subchondral bone. So in that situation, if we add an antero-posterior screw or a polar screw, is that strong enough to prevent this angular deformity which subsequently develops?
Possibly. That's what I said earlier, that earlier we used to just do the nailing like this. And now all of us, you and me, have learned that it can be improved upon by the multi-axial multiple screws and by the addition of the polar screws going subchondrally. So even the antegrade nail in a femur, lower 130 femur, it can work if it has been done like this. But I think that is very dicey. But my option is I'll do a distal femur nail instead of an antegrade nail.
No.
Yes, yes, doctor.
In a situation where you have already committed.
Sorry, Sangeet.
In a situation where you have already committed, you have already put a nail, and then you realize that the nail is not stable in a small distal fragment, or the fragment is too wide for that size of nail.
So I showed earlier, I will add up a plate on the table primarily. Because those 3 screws, if it is available, 3-4 screws in the nail, if it is available, it will be a better option along with those 2 or 3 polar type of screws onto the side, which will give you increased stability. But once I know that it is not stable, I will not hesitate to put in a subcutaneous plate.
So you want to conclude that type of fixation would be inferior to an augmented plate?
I would think so. Okay. I would think so.
Even polar screw.
एक minute. Dr. Gadigone, Asim has been, he has raised his finger. Yes, Asim.
There are even Indian nails which have got distal tibial nails which have got 3 and 4 multi-directional locking.
That's right.
One oblique and 3, one anteroposterior and 2 mediolateral. So still you will like to add an augmentation plate?
No, if you can get 4 screws, as you said rightly, and a subchondral bone, then I would feel it is perfectly all right.
Plus, about the dynamization, you always dynamize from the longer fragment. So distal third tibias.
Abhi dynamization will come. I am going to talk about
नीचे किधर उसको छोटा क्यों? We will like to have a subchondral nail and dynamize from proximal.
Sorry. Yes, Dr. Naveen, you were the one.
If the fracture is at the same level in the fibula also needs a fixation to get the stability. Otherwise, also there will be a problem of this angulation. And previously we were accepting angulation because our concern was the union. Now we know the axis maintenance and the ankle arthritis and above hip arthritis. So now we are changing to the function more.
I think when I started the nailing, when all of you were probably not into the picture at that time, we started nailing. Whatever purpose was, push a nail into the distal fragment and get the screws there into the lower end. And this is all what we started with. But then we realized that if it goes into the deformity, it's going to be bad for the patient. So over the years, we have all of us have improved. Yes, Dr. Gadigune, you want
to say something? The polar screw, they help in the centralization of nail, but the stability provided by them, it's a questionable. Because of the rotationary movements, there is osteolysis around this polar screw also, and they also fail. Therefore, if you want to at all, the screw should go through the nail. So multi-locking nail is superior than additional polar screw. That is how.
Agreed. Yes, Sangeet?
No, I disagree with Dr. Gadigone. In a given situation where you are left with only fixation of 2 distal screws, adding polar screw would make that construct stable.
So I think it is a different thing what you're talking, Sangeet. If the nail doesn't have a provision for putting in 4 screws, then in that situation, if you are stuck, you can improve upon the fixation by putting 2 polar screws.
Yeah.
Yes, Dr. Gadigune?
Yes, but the stability is still questionable.
Agreed.
Unless it is goes through the nail.
Yeah.
So through the nail, if the screws
No,
goes,
no,
they are better than
if the nail has no provision for
yes,
any
yes,
more screws,
that time you can have, because
Rather than-
that is the only option available with us.
Rather than leaving the construct unstable, it is better to add 2 screws, which will give some stability.
Yes,
rather
yes.
than leaving
Yes.
it alone.
Yes, finer
that's-
point
Ravi.
it is better to change the polar screw touching the nail with the friction, so that can give more stability than the polar screw little away from the nail.
now the situation becomes, as Gadigune mentioned, polar screws by itself is still debatable. The situation, it is what we feel that it will improve. So into the given situations where you are 4 screws which you have not been able to put and the nail is not subchondral, you can add up with polar screws, or the easiest is you put in an accessory plate.
Yeah.
Okay?
Thank
Yes,
you,
sir.
sir.
Now here is the nailing which is done. You know, in those olden days, this is way years back. We have done the nailing, but you can see there is an instability and the fibula also is not stabilized. So this is the one which is very likely to go down, and as you can see it, with the movement, it broke down. And once it broke down, the fracture healed up. So it's very peculiar that the stability was achieved after these screws broke down and there was some collapse occurred at the fracture, and then it healed up. Now here is the non-union. This has been there, I think, for about 16 years. Multiple operations, multiple things are done. How will you proceed now? If I can ask, starting with Naveen. I hope you have not seen this case.
No, I have not seen the case. The first thing is fibula is united. You have to one must has to do a fibular resection of the part of the fibula, and then again you can open up, clean up everything, and fix up with the nail or a plate, whatever fixation you can do, and add up the bone graft.
Hey, Naveen bhai, हमको menu card मत दे.
No, not menu card, sir. What I will do is I will do resection of the fibula, interlock nailing, good stability, and a bone graft. Cleaning up all the fibrous tissue at the union, opening up.
Yes, Sangeet, you want to add up something?
So there is
This
a
is
Say something different?
This is a very long-standing non-union of a distal tibia. It is also known as a phenomena of tibialization of the fibula. Patient
Yes.
must be walking on it.
Exactly.
But there is a severe osteoporosis will require 2 implants, intramedullary, extramedullary, as well as the bone graft plus excision of the fibula at least 2 centimeters to restore the length as well as the alignment.
Yes, Sangeet.
there is a plastic bowing of the fibula. So
As you said, as Dr. Gadigune rightly said, patient is mobile. 16 years, she didn't bother about it. I'll tell you how the story is. The patient neighbor got operated by me. And then the patient said, 16 years I am going on, though I am walking, but she wanted to be better. And that's the reason I think since the neighbor became all right, she ended up with me.
So a segment of fibula will have to be excised to align the tibia. That is one. Second is a compression which is required in this hypertrophic non-union. So only nail cannot achieve that compression. So you have to put a plate here. So my choice, rather than an intramedullary nail, would be a plate, provided the soft tissues are good enough.
Soft tissue after 16 years, everything is good.
No, there should not be scarring on the
No, everything is good.
Yeah.
Yes, sir. Asim, you want to add up something?
No, nothing, sir. I'll choose a combination. I'll open up the medullary canal, find out with gradually increasing drill bits, open up the canal. I'll use a nail and an augmentation plate for the compression along with bone graft, and a fibulectomy is slightly higher up than this level, not at the same level.
But why not Elisaro technique? distraction compression technique, that is the best instead of doing all these things.
I won't like my leg to be in an Elizaro for 4 months,
Yeah.
6 months.
Ek minute, Vasudev.
Yes, sir.
Vasudev, you genuinely will do Elizara on this?
No.
Your setup.
Uh,
I think Alizara is only indicated when there is no other treatment.
No other.
Nothing is left.
No other
Nothing.
treatment.
Yeah.
Anyway,
Amputation or Elizaro.
exactly. This is what I did. You can see the 3 screws distally, osteotomy of the fibula here, 3 screws distally, a dynamic. There is a proximal dynamic screw, 1 screw only, and you can see it over here. This is the now long time. This is completely healed up. This is 5 years. The fracture is healed up. She is fully mobile.
In tibia, weight bearing itself will take care of the union.
Yeah. I think उसका video है. That anyway, that is not important. So this is the one. But I will say today, if I was to operate after all these years, I will add a plate. That time I did it, I think I was very, I thought I am a nailing chap, and I did this nailing. Fortunately, it held up and all. But today, definitely, as you said very well, I'll do the plating also. Small, thin plate, about a 3.5 millimeter, 2-3 screws, and it should be fine.
You left one interlocking hole also empty, sir. You used only 3, you had option for 4.
Yes, you are right.
Yes.
Distally.
Anyway.
Yeah, distally. There were 4. He used 3.
Anteroposterior is remaining. Anteroposterior is remaining.
Anyway, here we come. Again, this is the plating which was done. 6 months, non-union. Again, it can be treated with a nail and a plate. As we were talking about, this is a nail and a plate. And this is in right subchondral. अभी ये इसको क्या करेगा? I tried to go right subchondral, and as I said, this right subchondral you can go only by taking up a guide wire which is non-beaded and ream it right from end cutting to the everything. Yes, Bolo? Sorry,
Sir,
Sangeet.
Sir, can you go to the plating X-ray, the first X-ray, where so in this, like, how do you take an incision? Is it through the same incision where you plate the fibula laterally and plate the tibia?
No, this tibia and fibula will need 2 incisions, no?
So the flap is so close then. If you take a 2 incision, the intervening skin is so close. So doesn't it devascularizes or undergoes a necrosis?
Sir, why the fibula plating was done here, and in future also why you want to do a fibula plating in this case?
If you do the plating of the tibia, you may not need the plating of the fibula.
Sir, here the plating is done by single incision. The plate is on the lateral side. Why?
I don't know.
Plate is not on the medial side. Sangeet.
I have inherited this case.
Yeah, I know, but the plate is on the lateral side. So what the surgeon has thought is something different. He may have gone through the same incision for the fibula and the tibia, I think so.
No, I don't remember now.
Because plate is on lateral side, not on the medial side.
Yeah. Anyway, this is how it was, and this is how it is. Now, how do you assess? How do you proceed?
Nail is already going inside the ankle little bit.
So, क्या करेगा अभी?
So pray God.
Let it get united and then remove it, sir. I don't think it will make a much problem just now.
If it is in the
what is the fracture side? How much is the gap at the fracture side, sir?
No, the fracture side, the gap is not there.
It is going anterior.
This is how it was a lower 1/3 fracture, so I went subfoot, and you can see here. This is the tibial articular surface.
Yeah, it's going anterior.
So I checked it up into the C-arm. before closing down, you can, I think all of you who have worked with me, you know very well, I not leave it just like that. So I checked it up, and this is what it is. So it gives you illusion because you can see the articular surface of the tibia.
And it is good that it is a beveled end. It is not a complete round end.
Exactly.
So
So obviously this held up very well. So that's not the issue at all. You can see everything is held up.
Synthesis.
what I was saying,
Whenever, sir, you feel okay, there are questions are coming.
Now we can take it up.
Okay, sir.
Because
Sir,
I think I'll also be much more comfortable interrupting like this.
Sir,
and all of you are so active.
Sir,
Yes.
previous
Bolo,
slide.
Gune.
Previous slide. Sir, here is the angulation because the nail is a straight nail. So it should have gone here. Did you bend the nail?
No.
No, there is no angulation. It is a projection. The plate and the nail projection is coming like that. That's why it is looking like that.
Naveen bhai, the centralization of nail in AP and lateral.
Okay.
So if there is no centralization, that means there should be a recurvatum or procurvatum.
But it is not there. You can see it goes.
it is, sir, the Gadigone, sir, it is a synthesis nail which has that typical tip which looks like this.
Okay.
And what I was saying was, in a lateral view, if it is in the posterior half, so in an AP, you will see it little longer penetrating the knee joint because that half or that side is little longer, if you can see in the lateral view.
Right.
It is in the anterior part, Sangeet, here.
No.
It is in the anterior part.
It is in the anterior
It
part.
is not in the joint. We agree. It is not in the joint.
No. If in an AP view, you see it little longer, and if you use this type of nail, but if it is in the posterior half of the distal tibia in the lateral view, it may appear in an AP view little longer or inside the joint. That is what I'm trying to say.
Yeah. So
Okay. Sorry. Yes.
Can I go for the question? Yeah. In the tibia, there is a one question for tibia. Dr. Vijay Khariwal, he's asking if in tibia fixation, he feels the fixation is not adequate. Can we support it with the above knee POP cast for 3 to 6 weeks?
I feel that plaster stabilization is not good enough. If on the, as Dr. Sangeet rightly mentioned and all of us mentioned, if on the table you feel it is not stable enough, and in the nailing you will be able to judge it, you try to twist the whole tibia, and you will know that it is moving. Then in that situation, it is much safer to go on and put a plate there. Because the plaster will be a very poor substitute for a plate.
Okay. Another question, but this is a wrong question totally. He's not knowing probably. Dr. Abhilash from the Mumbai has said the polar AP screw go through the nail only, I think. The polar screws are not going through this nail itself. Polar screw are not meant for to go to the screw. So that is the answer. The question they are asking is for middle third fracture femur, sir.
Abhilash, I think, is a spinal surgeon, if I remember it.
Abhilash Pohokar. Abhilash Pohokar.
I think he's a spinal surgeon.
Okay.
Anyway, carry on.
For middle third fracture femur, sir, which nailing, antegrade or retrograde you feel prefer?
For a middle 1/3.
Yeah.
That means if it is in the isthmus.
Yeah, they have written M/3. That is middle third only. This question is from Dr. Rajesh Siriskar.
Now, if it is a middle 1/3, that means if here is a fracture, it is the junction of the upper 2/3 and a lower 1/3. But if the fracture is here in the isthmus, where the nail can have a good fixation proximally and distally, then antegrade nail in a dynamic mode distally by reaming. Say if I give it the thing ream 418 and put in a nail of 410, then it will be a good and fix it up in a dynamic mode. That is the way in which it will head up.
Okay. Now he is asking about.
Sorry, anybody wants to add up anything? Same.
You will keep the dynamic thing distally or proximal?
In a middle
longer fragment should be actually having the dynamic mode.
That's why he is talking about the fracture in the center.
In the middle third. So it is either side. Both segments are same.
It's much
Both-
easier lower down than proximally.
Sir, I disagree with you, sir.
Bolo.
Because the dynamization effort, if you want to do it in the middle third fracture, it should be proximal near trochanter. If you
Okay.
do it in a distally, or single screw, there is a mediolateral translation movements of the nail. At the fracture side, it becomes micro movement and loosening at the insertion side. Therefore, it will be a more unstable construct. Therefore, if you want to do a dynamization, it should be proximal, not the distal one. That is my take.
We may agree to disagree, Vasudev.
Thank you,
I'm
sir.
talking about in the isthmus fracture, where there is going to be a good tight fit of the nail proximally distally. Your point is well taken, but I'm sorry, I don't agree. Maybe other people maybe agree. Anyway,
I differ that I do not do any dynamization at all, because not doing dynamization is not harmful, but doing dynamization may be harmful sometimes, not always.
yes, Sangeet.
The problem with the retrograde nail in a isthmus is you cannot go beyond the lesser trochanter for locking those two screws, the distal screws. So the fixation will always be compromised in the proximal fragment. For a middle third, probably the choice would be an antegrade nail.
Yeah.
Yes, sir. Asim, you want to add up something?
Nothing, sir.
And why to violate the knee joint when you have a middle third fracture? Why not to go antegrade?
Here it is what again I am coming to the same thing. This is the fracture which I felt was not very stable at the end of the construct. So I added up this plate and this has completely held up. Now this slide is for basically in the lower 1/3 fracture, the choice of treatment, first choice of treatment is the distal femur nail. Second is if you've done an antegrade nail, and then if you find that it is not stable enough, add up a plate. Or you put in a 3 or 4 screws distally and subchondral as much as it is possible. But antegrade nail with only 2 screws, which is normally available, is probably not appropriate.
Sir,
Yes, Sangeet.
picture number 3. The picture number 3, mark 3.
Yes.
The distal oblique locking, is it intentional or it can be done as an alternative to have better purchase?
I think it is in the system, it is available. That's what I know.
No, sir. This is your innovation.
My innovation, maybe.
This is not in the, it's free and oblique screw.
If I remember, this is, I have borrowed somebody's X-ray, but I am
Okay.
not sure about it.
So this nail has a provision for 3 screws from medial to lateral direction.
Yeah.
And the center one being dynamic, you have a play of putting an angular screw.
Angular screw.
It's in a different plane also, Sangeet. It's not in the same plane. It's a 40-degree oblique.
Okay.
Sangeet, now nails are available multi-locking system with 2 mediolateral and 2 oblique at 45 and 60 degrees.
Yeah.
Exactly.
These are not antegrade nail. These are retrograde nail.
Yes,
Retrograde nails.
retrograde.
So this is antegrade nail.
But in
Here
an
it is.
antegrade, there are only 3 holes available. Am I right?
Yes, sir.
Yeah.
Yeah.
Antegrade femur 3.
Yeah.
Tibia 4.
Cyrus has 4.
4.
Yeah.
Anteroposterior
4.
hole is also there.
Cyrus nail has a 4 screw. 4
Four
distal screws.
Okay. So this is what happens. Any idea why this has happened in the isthmus?
This is because of the unstable construct. Biology is there, but there is no stability at the fracture site because distally it is not locked, I think. Or somebody has done a dynamization.
Somebody has done a dynamization. You can see the screw.
Yes. Dynamization has been done. And why he has opened the fracture site?
Grafting he wanted to do.
What bone
And
grafting
this
has
is,
been
as
done
you
or
can
some?
see, 5 years multiple nailing surgery, yet no radiological unique.
But
Bone
the,
absorption syndrome.
these X-rays shows the staples with the immediate post-op X-ray. So he has done something at the fracture site.
He has done a lateral bone grafting.
Looks like
Not seen. Not seen.
not seen. Dynamization is seen.
Yeah.
नहीं उसने चूरा डाला होगा बोन का
चूरा डालता है तो नहीं दिखता है ना वो. Okay, dynamization is easiest and effective in a certain setup. And dynamization to me more appropriate on day one, but it can be done afterwards. Now here, if you dynamize, you can see in a dynamic hole if you put in, that is more proximally. And when the fracture collapses because of the multiple screws and here in a dynamic hole, the nail has to migrate up. It is the only way in which the dynamization can occur. So dynamic hole in the isthmus, whatever it is, and if you fit it on both sides and one side is the dynamic hole, this is what it has to happen. Now this is the typical dynamization. This is the fracture which you put in the screws. The fracture is separate and the nail is here. So when you dynamize it, you take out this screw, nail migrates it. I have exaggerated it in order to be more clear. So this is what is the fracture surface will go down and the nail will go down. Same thing in proximally, the nail, if it is done, the nail will go up. This is what you can see very well here. The whole nail has gone up. Nail has gone up after dynamization.
Yes.
So now here, so many times, even if it is dynamized, it may not work, because if there is a bone formation has occurred here in any one of the holes, or there is a small bone has traveled all the way down, or the bone is subchondral, or there is these implants which are there, the screw which is there, or there is a bone formation has occurred distally, or bone formation has occurred proximally, then it will not occur. So these are all the reasons why dynamization will not occur. So if you decide to dynamize, assess before dynamization, 6 to 8 weeks, do not delay. And very rightly, as Dr. Gadigune mentioned, if there is a small callus, it has a better chance of a healing after dynamization. See the distal end of the nail, there is a place to travel down. There is no bone plug. Here there is a bone plug, or here there is a subchondral. So there is no question of dynamization. Weight bearing after dynamization is helpful, or almost it is a must. And 2 months about before judgment on healing, fracture not comminuted, then only you dynamize. If it is a comminuted fracture and if you dynamize, if it is a comminuted fracture, you dynamize, there is a nail will go up and there will be unnecessary lot of shortening. So comminuted fracture is not dynamized, as you can see very well here. Before dynamization and after dynamization. Yes, yes. Bolo, Naveen, yes.
Sir, the another rule is of dynamization, do not remove all the screws from the one side. Here, he has removed all the screws from the proximal.
Yeah, otherwise, how can you dynamize?
Both the
Oblong
screws
hole
are
is
not
there.
required. Both the screws are not required to be removed. Only static hole should be removed. If you remove all the screws from the one segment, it becomes unstable.
If you see here, this is an older type of a nail.
But you have to keep in the dynamic hole one screw, and a non-dynamic hole you can remove it. But the principle is not to remove all the screws from the one side.
Yeah, we have done doing it after about 2 months, 8 weeks or 2 months. Would it make a difference?
Yes, sir. It will give instability. You do not have, this is for the axial compression, but rotational stability is required at the same time.
Okay. So this is if it can go down, if you dynamize in a comminuted fracture, lower down, it can go down occasionally. Now the point of entry in the tip of the trochanter, when we talk about, this is the easiest point of entry. Which surgeon take this point of entry? The ideal point of entry is in the tip of the trochanter or in the piriform fossa. If you go on the tip of the trochanter, then you read it, you will break this completely, which is desirable, and so the point of entry will become almost in the piriform fossa. In Dr. Gadigune's time, there is nothing like a piriform fossa. Am I right, Gadigune?
Yes, sir. Because
trochanteric fossa.
It is a trochanteric fossa.
Yeah. Yes, Dr. Sangeet.
Sir, have you completed dynamization?
Yeah. शायद आएगा दूसरा.
नहीं.
शायद आएगा.
Just wanted to ask a question. Don't any of the panelists don't feel offended. Dynamization is an old terminology. Does it exist today? One. Second, like if you have to give a message and understanding the static holes, finding the static hole, putting the screw properly, if you, the scenario all over, there is so much of confusion rather than a simple message is all the fractures should be statically locked by two screws proximally and two screws distally. There is so much of confusion, which is the dynamic hole. Sometimes with the Indian implant, they are not matching. Either you are putting proximally or distally. So to, and if it is wrong, then you make the construct too unstable. So to have all that confusion, it is better to lock two screws proximally and two screws distally one. And does the dynamization really works? Or should we do it today?
Yes, Asim.
Sir, as Sangeet rightly pointed out, and I think Naveen Bhai also said that two screws above, two below, and the static locking is the stated norm from AO and all those people. But in practice, in last 7-8 years, I have realized that for ischemic type of fracture, what you are saying is correct. All those Swiss and American Goras sitting 5-6 of them, they recommended that we do static locking and almost 9% unite. But from practical experience, I am convinced that what you are proposing, that ischemic fractures, you do a dynamic nailing on day one, you will not regret it.
But it is difficult to get the message, so it is better. There is a
It's
benchmark study
It's
that 98%
98%
unites with the static locking. Yeah.
Tycoon, yeah.
Or those who are not united, they have united at the delayed time, but still they have united. That is the benchmark study.
Yeah.
Okay. So I think that most of the people make this mistake on this point of entry. The point of entry which is here, which is not an adequate thing, it has to be right there, or it is a point of entry which is in piriform fossa. For all the proximal fragment, the point of entry should be into the proximal, into the piriform fossa. For a shaft femur, it can be into the GT here. Now here it is. You can see here, the point of entry was in the GT. If it was in the piriform fossa, it would have been directly going like this. Now here, if it is in the GT, then it will hit here, and this is exactly what has happened here. This was there was no fracture. The point of entry in the GT, so this automatically this butterfly occurred. Fortunately, it held up. But if in case it was in the GT, then it would have not occurred. That's the reason I feel the point of entry,
Sir,
piriform fossa, is more desirable. Yes.
Here the nail is straight, so it has to be through the piriform fossa. Design is different. There is no angle of the nail, so it has to be through piriform fossa. Here the mistake is the nail design is not meant for a GT entry. If the nail is made for the GT entry, it would have also worked.
A2FN.
It is a straight nail, sir. It is a straight nail.
No, A2FN has got a band. A2FN is trochanteric entry.
But this is not A2FN.
This is trochanteric, yeah. This is piriformis fora.
Yeah, it's a straight nail design. There is no proximal bend, 4 degree to 6 degree, whatever.
Yeah.
And if nail has got a bend, the right side and the left side nail will be different.
It will be different, yeah.
Different. If there is no bend, it's a piriformis fossa entry, then nail will be same for both the sides. It will be universal, right and left both same.
Only for a longer version, no? Not for the shorter version. Or the companies for shorter version, they make same right and left.
Yeah.
Now here, this is where the debatable issue for fractures of both the tibia and femur at the isthmus. Again, I am saying at the isthmus. My approach is transverse fracture at the isthmus in the treatment beam, 1 to 1.5 millimeter, adequate size nail, not a canal stuffing, pushed by hand and not hammered except at the end. In a dynamic mode, means at the extreme end of the things, through at one end and full weight bearing on day one, forget about it, the fracture will heal up. Basically, ream 430 and put a nail of 410 in a dynamic mode. This is what I have been treating them. Unfortunately, fortunately, I didn't have any problems with this. And we have just now seen the some difference of opinion, so we leave it at that. Yes, Sangeet, you want to add up something?
What do you mean by overstuffing? Oversized nail, do they create any problem?
The nail should migrate a little up and down.
That is intraoperative, but post-operative healing.
No, it doesn't make a difference. Then it doesn't make a difference. Yes, Negi?
You are using most of the time, almost always imported nails. So they can be short down the canal with just reaming 1+ or 1.5. Most Indian nails have a very thick wall. They are very rigid. And invariably you end up reaming 2+. Suppose
Agreed.
you want to use 12. Yeah.
Agreed. Yeah. Even in a Cyrus nail, you will need to do the 2+. Otherwise, the Cyrus has got a anterior bow which is much more, and that's the reason why it will not be able to go. Yes, Garigone, any opinions?
I believe in a dynamic nailing in a diaphyseal fractures, not in the ends, but dynamic.
No, it is only in the diaphyseal I am talking.
It's only in this.
And I have no regrets.
Repeat suggestion, transverse fracture with a good bone-to-bone reduction into the isthmus area. There is no need to do a static nailing, only do a dynamic nailing. And these are what some of those pictures. This is the dynamic nailing. And once the fracture heals up, the nail will migrate down below. The whole screw will migrate, or the nail will go up a little, and you will get the healing process. All these are the dynamic nailings which I do. And as you can see it here, this is the dynamic nail, proximally which I have done it. And this thing is completely healed up. So comminuted fracture reamed only in the canal, bypassing the comminuted piece. Canal stuffing thick nail to avoid early breakage. Static mode, never dynamize. Secondary bone grafting if needed. Maintaining the length even if some fracture segments in this fraction. Like the fracture like this. This is the one which has been equal length has been established on both sides by putting this nail. This is many years back. I think probably Dr. Sangeet might have been there.
I was the assistant.
You were the assistant.
I was the assistant. Bhatia में किया था ये.
1990 में तू था.
मैं नहीं सर, ये उसके पहले का है. I was assisting this patient. I'm aware of.
अच्छा. ये है Radesh Shyam, if I remember the name. Radha Krishnan, yeah. Then ultimately
grafted at 6 weeks.
After it was grafted after 6 weeks, and then the fracture heals up. So here it is. You just graft it, and now all this sort of a fracture, you don't need at times anything. Or if you need the grafting, it heals up. All these fractures, they heal up without doing anything. So even if it is like this, it has no problem. Occasionally it heals up. If it doesn't heal up, then graft it, but don't dynamize it. All these things have healed up. So I think there has to be a differentiation between a butterfly, young people, and the bone crushed into the elderly people. So these are the two things which you want to be clear. Bone crushed in the elderly people, they are the ones which are different comminuted fractures, while these young butterfly pieces, they will all heal up if you put them aligned and given the good static nailing. So today what I do is I dynamize on day one all isthmus fractures. Please understand again isthmus fracture. Hardly do a secondary dynamization of my own patient. Many of the other at times I do it. I feel a second surgery, everything should be done. It may be an overkill. Second surgery, I often use a plate, nail, and a medial graft. Attitude of doing everything. I am only in a private practice, and that's the reason this is how I think, and it pays in the long run. Now here it is. This is the one which is dynamized, as you can see by taking out the static nail, and then this thing heals up very well. Where ideally dynamic nail should have been done to me on day one. Now here it is. We already yes.
That tibia, suppose it had an intact tibia, there was no fracture. So if you are the primary surgeon, will you cut the fibula or you will keep the fibula? I don't cut it. I do a reamed thicker nail.
I think that is a debatable issue.
What will be your advice?
Quite a few people like you feel that it need not be cut.
Yeah.
I
11 mm nail.
I have seen a few of them going into non-union. So I inform the patient and I do the primary, I do the primary osteotomy slightly away from the fracture. And I have not regretted that. Whether it is needed or not needed, I think it is a debatable issue. And
Sir,
any opinion? Yes.
Sir, does it depend on the how much gap it is? If it is the slightest gap, you do not require to remove cut the fibula, I think.
Yes. As I
If
said,
it is a larger gap, does it any relation variable with the gap of the fracture site?
When the fibula is intact,
कैसे गैप आएगा?
that gap आता ही नहीं है, थोड़ा ही gap होता है.
इसीलिए mostly we don't require it because the stability, once the stability is taken care of, I think it works.
It is the reason I am saying it is a debatable issue, and I, as a 100% precaution, I do the osteotomy. Which if anybody say no, I don't do it, I'll agree about it.
Okay, sir.
Yes,
Sir.
Dr. Sangeet, you want to add up something? You raise the finger?
So,
No, sir, no, nothing.
sir, may I comment?
Yes. It is,
Sir,
you have been invited to do that.
Sir, you have removed the static hole.
No, it is not my case.
Whatever it may be, but the fibula is intact. How the dynamization will help? You can see
It is exactly what I asked him when he showed me this. And he very cunningly had not shown me this X-ray. It is in the meeting he showed me. I said, ये कैसा होएगा? ये तो fibula intact है.
It's not because of.
And then he showed me this case. This is the X-ray he showed me. And still you can see.
So it's not because of the dynamization. It's a natural process of healing has caused union because.
No, it is, I think here.
No, sir. No.
Maybe whatever you say, maybe.
Right. Sir.
Yes, sir.
The tibiofibular syndesmosis higher up and lower down is not a rigid joint. It's not fused. There is some micromotion allowed. It's a joint.
Yeah.
Okay. As I said, when I asked him the same question, when he was junior chap, he was asking me into the meeting. I said, ऐसा कैसा काम करेगा? ये तो है नहीं. Fibula osteotomy करेगा तो मिलेगा. He says, so here is the X-ray. Next X-ray. Okay, this we have spoken about. Now here was this lateral grafting. Quite a lot of surgeons do it because it is easier to do it. And here it is. It was dynamized, and still the fracture did not heal up. And these 3 months, and then ultimately I did the exchange nailing. As you can see, I did the exchange nailing. I put the nail a little short. After reaming this, I put a little short, and then the whole fracture healed up. So I think basically the isthmus fractures have a very good potential to heal up if it is done in a dynamic mode. If you do a exchange nailing, it is almost, to me actually, exchange nailing is almost always in a dynamic mode, and it has an excellent chance of healing. Science or a bravado. We talk about it. Now, do you allow this patient to walk in this sort of a comminuted fracture? Dr. Garigune, if I can ask you.
Sir, I don't allow them at least for some signs of healing are there.
Yeah, yes. Asim, you want to say something? Asim?
It will depend on so many things. Patient का वजन कितना है, 12 mm nail है और 40-45 kg का patient है. Maybe partial. Actually, it's never a non-weight bearing. It's toe touch. 10%, 15%.
एक सेकंड, ये हम सबको ऐसा ही पूछता है. toe touch मतलब क्या? toe touch मतलब क्या?
There is nothing like toe touch.
Exactly.
Assisted weight bearing with the walker. Assisted weight bearing walker. But the more
it conventionally toe touch.
No. The Goras now call it weight bearing as tolerated. WAT.
अभी बदली किया.
As per the pain toleration, yes.
So but I think with the walker, you do not have to do a lungry. You can put the but full weight bearing is not desirable. It's
Sir,
such a comminuted fracture.
Sir, here the only one point is that the alignment should be good. Otherwise, there will be point loading. If you are putting a load, the alignment is a very important variable.
No, here you can see the alignment. It is a good alignment.
But in the other plane, you see, it looks like there is a bend.
No. This is after walking. This has happened.
Okay.
That nail is very thin.
Yeah, whatever it is
Very
there.
clear.
Now here it is that what you were talking about, Asim,
Yes, sir.
conserved, not healing up. 6 months it was, I remember very well. So ultimately all what I did was the nailing and a small osteotomy. That time I used to do excision, but now I do only the osteotomy. And this is the same again. Here it was a nail fracture which had not healed up. So this is what I did, the osteotomy and healed up. And all this is the one. So today I do a primary osteotomy. As I say, good or bad, I don't want to go into the debate. And this sort of a comminuted fracture is no osteotomy, and I did the grafting, and ultimately the fracture healed up. So if this is an intact fibula, and the nailing which is done, this has ended up into a non-union. This is the nail which is thin, I agree. This is a very thin nail. Probably a thicker nail would have worked there. And ultimately it just works by doing a small osteotomy and the nailing which is done. This has worked for me. Right or wrong, I think it is a debatable
Previously,
issue.
it was a K nail, sir, and you changed to interlock nail.
Interlock nail,
So
exactly.
totally, it's a different thing. Interlock rotational stability has been enhanced
So
also.
Now that is the reason why I have called all four of you who are very competent surgeons to, if in case we have a difference of opinion, I think I want you to express that. Yes, Asim?
Sir. You have done a fibular osteotomy almost at the upper third fibula.
Yeah.
Will it be okay if you do it slightly below the tibial fracture site? Because for most people, they will bugger up the nerve there.
At a different level of a fracture. Upper, niche, it doesn't make a difference. I agree.
Yeah.
But sir,
You are worried about the posterior.
Now, many of them will probably damage the nerve.
I agree. Yes, bolo.
that was I was telling, if you do a osteotomy below the 6 to 7 centimeter from the fibular tip,
10 centimeters.
Yeah, I agree. Entirely, I agree. No question about it.
अभी एक दो जूनियर मिला साहब, वो बोला तन्ना साहब तो फिबुलेक्टमी करता है, आप ऑस्टियोटॉमी क्यों करता हो?
नहीं, अभी फिबुलेक्टमी पहले करता था, अभी तो ऑस्टियोटॉमी करता है।
उसको चिट्ठी नहीं भेजा ना अपन लोग।
चिट्ठी नहीं भेजा तो हम क्या करेगा?
वो बोला मुझे आप फिबुलेक्टमी करता साहब, ऐसा करता है।
Nailing gives a good stability in isthmus fracture, but into the distraction can be harmful. Dynamization in time within 6 to 8 weeks can help, but otherwise, now here was the fracture. This is my treated. I did the nailing and I did this grafting here because this was a dead bone. I did the grafting and still it did not work. Somehow I think the gap which was there, which I had filled up with the bone graft, still it did not work. As you can see, this is how it has ended up into. As I said, this is how I inherited this patient. This is how I operated upon static nailing with grafting, and this is how it ended up into.
The circlage wire was the culprit. Because of this, there is a dead bone, is a vascular problem.
So that's the reason I have removed that dead bone. If you can see here, this dead bone, it has been completely removed. And I put in the bone graft, and I felt this is going to be enough. But this didn't heal. In 2 years, it didn't heal up.
There is a double voice.
I know
somewhere it's double started. Someone has started double.
I am not.
You're not. Now it is gone. Yeah.
So now क्या करेगा?
No, this is a vascular problem. We have to do exchange nail, plating, and bone grafting.
Yes, anybody else? See,
Sir,
it needs to the audience. I want to tell you how all these are the 4 expert surgeons. I really respect their expertise. We all at times disagree on certain things. Most of the things we agree upon, but at certain things we have a slightly different approach to everything. So here as very rightly Dr. Gadigune mentioned, you want to do nailing, plating, and grafting. Am I right?
Yes.
You said that?
Yes, sir. Yes.
Yes. Asim, you are muted. Asim, you are muted.
nail definitely thicker than this, at least 1 mm thicker.
No, no,
And
this
the graph,
it was the thickest possible nail which was there. You can see here.
we arrange for a thicker nail than this, and augmentation plate, and I always take graft, almost always take graft from the posterior iliac crest.
Yeah. Yes, Sangeet, you want to add up something?
The strain theory which you had shown 2 slides earlier.
Sorry.
The strain slide which you have shown earlier. If you go by that. Now, this construct is stable. That means the problem is not with the implant. Here, in other situation, there should have been new bone around at the isthmus, which has not happened. So this is a pure biology, which is not throwing the callus.
No,
so the nail which is there for 2 years, probably mechanically it is weaker now. So that is the reason it has to be.
I presume you are all seeing this, huh? This is on day 1. This is how it was.
Sir, can I?
8 minutes. First have the clarity. This is how it was operated upon, nailing and a massive bone grafting. This is how it has occurred in now 2 years. So I think you should opine after doing this.
Yes,
properly.
sir. Can I, sir? Can I,
sir?
sir?
8 minutes. Dr. Sangeet is completing.
Okay.
So this present X-rays are 2 years follow-up following the previous surgery.
That's right.
So here we don't see any callus in spite of a good fixation. So the problem is with the biology, and it requires a good graft and additional implant, whatever you can choose, either a thicker nail as Asim has suggested, or even a combination as Dr. Gadigone has suggested, either of them. But the main problem here is a biology, which we have to put adequate number of graft, adequate size and volume of graft.
Yes, sir.
Probably with the comminuted fracture, and we feel in a static X-ray that we have locked both sides, even though there is an invisible instability. So there is not only a biological problem, there may be a mechanical problem also. So both has to be tackled, and it needs augmentation, because only the nail and interlock is not giving enough stability, probably because these are X-rays are not dynamic. So there is an invisible stability, so need complete thing, exchange nail, graft, and the plate augmentation.
But sir, Naveen,
I want to add, if at 2 years, if it is an instability which is a cause, the nail should have broken by now. Am I right?
Not always.
By a year with so much of gap.
Patient is taking care of, not weight bearing at all. Patient is taking care, not weight bearing. It may not break.
If he doesn't weight bear, it won't break down.
No. But sometimes, sir, with a fibrous union, they have carried on for 5 years. My patients, at least 3 of them, 5 years, 7 years. And there is a pakka non-union, but there is fibrous stability.
It is very easy to actually, when you, sir, there is a, you can test the instability of the construct after opening the fracture. You just destabilize proximal fragment with the Steinmann pin or something like that, and just rotate the distal fragment. If there are movements, that means it's unstable, needs exchange nail. If there are no movements, then you can augment after compression.
At 2 years, in any case, we'll replace the.
In case that is.
In case it's 4 months, 6 months is fine.
This is what was done. Fibula, plate, massive grafting. There was an instability. And with this X-ray, as Dr. Gadigone had initially started, the biology is affected. Since the biology is affected, I chose this. This is the fibula which goes inside, then it comes in the other fragment. We all know it has to go all the way down. This is after 2 years. solid union. Now this is exactly as I was telling. All of us have a different approach. And one person will also have a different approach. Supposing I had not done this, and probably I was to do it today. Not necessarily I'll do this. I may do the same thing as it has been mentioned, augmentation, nailing and plating. So,
Sir,
but this is basically the biology has been looked after, the stability has been looked after, and this is what it is. Yes, yes, Dr. Gari, go ahead.
The principle is the same, intramedullary and extramedullary here.
Yes,
because
exactly.
this segment of the fibula which you have put inside the medullary cavity, it is exactly acting like a nail because it's a very strong structure.
Absolutely, absolutely. This is what
Sir,
I'm saying. So this
sir,
is like a double implant.
Yes.
Yes, sir. How
But
you
the fibula also adds up to the some osteogenic property.
Yeah.
After 6 months. After 6 months.
Yeah.
Yeah, but how you slided the fibula, sir? Have you used the proximal entry of the nail to push it inside the canal?
No, ये है ना, दिखाया ना ये तेरे को.
But sir, then there will be a very short length in the distal fragment. What we do is we push the fibula from the above. Yeah, from above we push the fibula to get exactly.
See, you can see there is such a big nail, a big fibula goes in, comes out here, push it up into the distal fragment, and then go on pushing it out with the small drill holes, the small K-wire holes.
Sir, why Naveen from the upper end? Because already there is a medullary.
Already there, sir. What we recently I did in the humerus nailing fail, I passed the fibula from the nail entry itself. Pass from the fracture site, then I pushed, keeping the reduction so that I can have an equal length on the both the sides of the fragment.
But see,
that is
fibula is not absolutely straight. So you try to hammer it down, it will break down, and if it is stuck in between, you had it. Anyway, this is how it was done. This is how I always do it like this, so that you know it is. You will check the mobility. First, you will check the mobility in both the fragments. I push it in proximal, I push it in distal. Once it is mobile on both sides, now I push it in one side and push it in the other side, and I mark it in the center wherever I want it to be 50-50. So it is marked there. There are a small K-wire holes are done through which you can push it down below. And then ultimately, as you can say, this is held up in 2 years' time. Patient was always on a partial weight bearing.
It has also increased the strength of our screw hold.
Yes, exactly.
But
probably one more thing.
One thing, sir. Can I ask you about your technique? Because I'm confused a little bit. The question is, if there is no loss of the bone on the medial side, you would not be possible to, after reduction, to get the K-wire in that all or push like that. If it is a complete circular on the both the sides, it won't be it will be very difficult to push on the other side further. Here there is a gap on medial side, so you had a chance to.
No. Here it is the gap.
If both the fragments are reduced, then and then you will be able to pass on the other side.
You will have to distract a little.
You distract it.
The fracture. You will be able to get that.
But once both circulars are same, how will you pass the fibula on the opposite side?
Gap create karta.
By distraction, you do the gapping. You do the angulation. You adjust it here. You can see it here. I am trying to push it. Here it is the same thing. This was intact.
Naveen bhai, for more clarity, read the article published by us in 2017, Indian Journal. It is exactly on the same problem what you are facing now.
Yeah. Asim, you want to add up?
Sir, as you rightly said that probably today you will do a nail with an augmentation plate and the massive grafting, which you did because the patient will be almost full weight bearing within a week or two and will be back to job.
That part of it, I have a little different point of view. Even with the plating, I don't make them non-weight bearing. They have a walker which is whatever is the partial weight bearing, which is pain allowing. If they all start, even the primary fracture also start the same way. I don't keep them non-weight bearing. They are not
No,
full weight bearing.
It is about his ability to go back to his earning. Or suppose I am the patient. Possible. When can I start working?
No, you will be able to start work. No, it will be the same thing. In this construct, it will be the same thing, whether the nail in a plate or this thing. But anyway, I entirely agree with you that the nailing is a far accepted treatment, nailing plating.
Yeah.
But with this sort of a biology affected, I wasn't very happy. You can see here the whole thing is necrotic here.
Okay, sir, can we take one or two questions in
You
between
take
so
as
that
many as you like.
so that they remain interested in the talk. The one question from Dr. Rajesh Siriskar is, how early you graft secondarily in the diaphyseal fracture not showing the union? What is the exact time limit from where you think that I will graft only?
About 2 to 3 months, I would say. 2.5 to
about
3
2
months.
to 3 months. Anybody has any difference of opinion?
Any opinion?
If there is a progressive pain, then it needs instability and bone grafting. If the pain is subsiding slowly, even after the gap, you may hold on bone grafting. Probably this fracture may unite.
Okay, Asim bhai.
Asim.
Sir, do you ever use only type of graft? जैसे स्पाइन करते हैं तो ऊपर रिब रख दिया, उसके ऊपर वो जुड़ जाता है. तो do you ever use?
Yeah, I think I have shown that case. I think you would know, Dr. Sangeet, that olecranon non-union. I had put in that.
I have seen that. Yeah.
Yeah, that's right.
Only graft. Okay, now again the question is here. Have you gone through the fibula in the fixation in this case with the screws are going also through the fibula part of the graft?
It is exactly what Dr. Kadigune said. It improves the fixation because it goes through the fibula. So you go half cortex, you go full cortex you go half cortex of the femur, half cortex of the fibula, second half cortex of the fibula, and then other half surface of the femur. So you will while feeling also you will be able to feel almost all the time.
Okay, now the question of Dr. Rajesh Siriskar previously asked middle third fracture. Now he has changed, it is below isthmus. What will you do? Retrograde or antegrade nail?
As I mentioned, I think it has been cleared out.
It is retrograde.
My choose is a retrograde.
Okay, and one question has come, probably he is asking Dr. Ankit Amin that, sir, but putting the plate in nailing will lead to a loss of fracture hematoma. So should we do that? He's asking about I think probably fresh fracture, or he's combining two other conditions, fresh and non-union.
First is even in a fresh fracture, you do a MIPO plating is not going to be harmful. You're going to do a nail and then do a MIPO plating as I showed you in that case.
Okay, there are questions about the infected non-union by Dr. Mohapatra, sir. Dr. Mohapatra, RN Mohapatra from Ulhasnagar. Sir, in delayed...
If we can ask Mohapatra, what is your solution? I'm sure he'll tell us.
RN Mohapatra, yes.
Yeah. He is a very competent surgeon.
Yeah.
We all know antibiotic nail followed by an antibiotic regime and exchange.
No, sir. His question is different. He's asking from the literature. Sir, in infected non-union, what further investigation, especially in understanding complex articular non-union, you would prefer CT, MRI, or indium-labeled leukocyte scanning, or 3 separate cultures? Which is more helpful? He has asked for 4 things: CT, MRI, medium level leukocyte and the separate 3 cultures. Yeah.
Usko साले को सब मालूम है. Sangeet, you want to answer that?
No, sir, no.
Same. Mahapatra is asking, huh?
Yeah.
Very, very well informed surgeon.
No. This is basically he's asking for other audience.
Infection.
Yeah,
probably the
infection, corrected ESR, CRP, MRI.
Suspected infection. Now he is asking this question. What investigations you will do?
अरे वो
Aspiration and cultures would be the most relevant investigation.
Most relevant.
Yeah.
Yes, Gadigone.
And
Asim,
CT and
Asim.
MRI, CT
Asim.
and MRI for to know the structure of the whether union has been done. It has nothing to do with the
असीम वो
जी।
आर्यन महापात्रा जी टन्ना सर के भक्त है वो.
मुझे पता है सर, मैं सर के साथ 11 साल रहा हूँ और बम्बई भी. तो every meeting he is there. Every meeting he is there.
Another question from himself again. In non-union, do you feel non-invasive external bone stimulators like electromagnetic stimulators, low-intensity ultrasound has any role? And any role of percutaneous injection of autogenous centrifuge bone marrow aspirate? Three modalities.
First, I talk about ultrasound.
Yeah.
All that is an additional measure after a good surgery. For your peace of mind, we can do all that. Bone stimulation, shock treatment, ultrasound, and all that. But I don't think it is a substitute of our surgery. Second thing is the injection of a bone marrow. I have my own reservation. I'll ask first the other faculty. Yes, Asim, what is your opinion?
Yes, sir.
It works when it's not required.
No, I can show one case if the time allows. I can show the one case where it helps, where it doesn't help.
No, Naveen bhai, if you had not done this, probably if you have done a good surgery, it was in any case going to be
I will show that good surgery has been done. Good surgery has been done. Still, it has worked. It was not working surgery only. I will show one case.
Yes,
very low subset of the patient, very small subset of the patient, it works.
Yes, Sangeet.
Yes, to continue, that subset of the patient will be the one who are not throwing enough callus at 4 months or 6 months or beyond that. And about this, we have spoken since generations. Since decades, we are talking about bone marrow aspirate. And if you compare with the synthetic bone, autogenous bone, a cortical bone, probably that is the most promising at present as per the literature in this section of non-unions, where you require only biology. Mechanically, it is stable. Biology is failing to throw callus at adequate time. So probably in them, the most commonly available graft, okay, without any intervention, it can be aspirated and it can be injected at the proper site. So probably it has the best osteogenic, osteoinductive properties as compared to any other synthetic graft. But again, it is only in a particular section of non-unions.
Dr. Gadigone, are you there? Dr. Gadigone? Okay. I'll add up a little. When they talk about the bone marrow aspiration, from one side, you aspirate only 1 cc, 2 cc. And anything more you aspirate, it is all serum which is coming. You are not getting any bone cells. So if at all you want it, you will have to go on aspirating at 5 sites or 10 sites and then centrifuge it and then put it locally. I don't think anybody does that by and large.
Sir, can I share that case relevant to that?
Yes.
If you allow, Temporarily, Sir.
Share yourself.
But you have to stop your sharing. Otherwise, I think it is allowed to you only. Still, it is not allowing. It is allowing. Now it is allowing. Now it is allowing.
And I want to tell the audience, there is no one answer for anything in orthopedics.
Yes.
So you have to see the spectrum, small difference of opinion, and that is the purpose of 3-4 people. Otherwise, if I wanted to sell only my thoughts, I wouldn't have called these stalwarts who have come here in the meeting. All of them are stalwarts.
Asim bhai.
Yes, sir,
this is the situation at 24 weeks. Young patient, interlocking done on the both the side. I don't think stability is a problem, but still it is not showing any callus. 24 weeks. What will you do? Sangeet and Gadigone sir and Asim.
Why do you say stability is not an issue? Because the nail
Required a
is
plate,
a loose fit in
augmentation.
the nail is a loose fit in a distal fragment. It doesn't have any bony contact
Yeah.
as compared to the proximal fragment.
There is
And
not
probably
much.
And,
There
and
is
Sangeet,
not much.
only two
There is no
monopolar
much pain. There is no
one
much
plate.
pain. No limp. No limp. No pain. Mild pain is there, and
in
the
spite of
X-rays. Yeah, continuous X-rays are showing like this.
at 24 weeks, in spite of good
Instability is
fixation,
rotational.
Right.
at
You are
24
right.
weeks, in spite of good fixation, it is not throwing new bone in this area, which is a
Anybody
good
will go
muscle.
for dynamization?
No.
No.
It 24 weeks, it does not work.
It does not work. Yeah,
Minimum period
absolutely
is
right.
only 3 months.
Let me see whether
maximum period is 3 months. Yes, you are right.
And sir, you can
28 weeks. This is the condition.
Sorry, you were saying something, Gadigone?
Sir, this is the nail is a straight nail. Is it an angled nail or a straight nail?
It is a straight nail. It is a sun nail. You can see it's a sun nail. Straight nail.
I think that doesn't make a difference here. No, would it make a difference?
Because it's a just below the isthmus fracture is.
Yeah, exactly.
And the nail is well fitting in the isthmal area.
I will still do a exchange nail with a bone grafting. As Tanna sir said, medial bone grafting, exchange nail. Just the distraction should be completed by just back blows. They do a locking and bone grafting. Probably it will heal because no need of doing, I think, plate already because the quality of bone is good and there are some woolly callus formation is still there here.
Yeah.
Because you can see here, you can
Dr.
see
Sangeet?
here on the
Yes,
first X-ray.
Yeah.
There is some semblance of some reaction.
Yeah. Here it is.
Yeah.
Some reaction is there. Yeah. Then at 28 weeks, this is the condition. Then at 32 weeks, this is the condition.
No pain, as you say.
No much pain.
Wait.
It should entry should be from the piriformis, but the entry has done a little
fine.
lateral to the piriformis.
That is fine. That's not.
That is fine. That is fine.
This one, as Gadigune says, and I say, it will heal up in due course of time.
Due course. If there is no pain, it will heal.
It will heal.
But 32 weeks, already 8 months.
Yeah.
This is a radiological picture. This is not a biological picture.
That is
Because
where
you can see-
somebody asked when you will put a bone graft.
No, but then pain is I think it was mentioned by Gadigune also, and we have been talking about it again and again. If patient doesn't have a pain, that means it is a good thing which is slowly healing.
Patient is having some pain,
Anyway, you proceed
little
in
pain.
your case.
That's why it is consulting and looking the X-ray is worried. So he's going for consultation to various surgeons, and various surgeons has a different opinion. Here we did aspirate like this bone marrow, and you can see at the 36 weeks it has started healing. Within 4 weeks and 40 weeks, you can see a good union,
So Naveen
which was
bhai,
not consistently seen for 36 weeks, 32 weeks.
So Naveen bhai, in a new definition, after 6 months, after 6 to 9 months, even the 9 months, then we have to declare it as a non-union.
You are right. You are right. But here, non-invasive procedure has worked very well. So this is also a possibility. Then I saw the literature. The bone marrow, when does it help? It is a low morbidity. 75 to 90% is the success rate. These are the papers. 2013 and recent papers are also there. But there is a caveat that defects should be less than 5 mm. There should be a stable construct, no sign of the infection, and the donor itself, the patient should not be smoking. Good number of progenitor cells. That is what literature says. That is the message I want to say.
Now, how many cases it has failed in your hand?
No, I have done very limited number of cases. I am selecting this type of the patient only, but I have not a complete study. This is a one
I think
case.
These are all case individual 1-to-1-2 cases.
Yes, 1-to-1-to-1-2 only. You are absolutely right, sir.
Naveen bhai, in this case, is it difficult to say? Is it because of the natural process, or it is because of your osteoporosis?
But natural process was not working since 32 weeks. So why the natural processes work within 8 weeks?
Naveen bhai, I have a question to you.
Yes, sir.
When whichever non-union you add a graft, have you ever seen a union in 6 weeks or 8 weeks time?
Exactly. So it is whatever.
It takes at least 3-4 months.
Only thing you can see at the 8 weeks also union many times in the fractures.
There is no debate. It has united.
It doesn't unite.
But any graft will not make a non-union unite in 6 to 8 weeks time. That is what I'm saying.
You are right, absolutely. You are absolutely right.
Same way Gadi Gune mentioned, there was some sign of reaction, some sign of activity was there.
Yeah.
And it was healing up. You entered at that time and you took the credit.
No, it was, sir, if you see it was 24 weeks.
24 weeks.
No, sir. It was 20.
It has worked.
24 weeks to 36 weeks. So that was a very long period. That was a long period, sir. 24 to 30.
You have the answer of Dr. Sangeet.
No, I do not have answer. I have only one case here, just with a full follow-up. That's why I have put because this question came. Only.
No, we understand.
Yeah.
Okay.
So I put it. That is only
idea.
you can yeah. So it becomes relevant. That is the only issue.
Now I think we'll go to humerus.
Yes, sir.
What has happened? I think you might have seen. I have shown this again and again at times.
Yes. I have seen this case yesterday or day before yesterday.
Yeah, I think some time back. So this is the one, the surgeon, it was operated in Singapore. Surgeon tried to push it in. Nail wouldn't go down. It was jammed here. And once you push it in, it got jammed more. And then he tried to take it out. It wouldn't come out. So ultimately it was left there. And then you can see it's going out. And then he came over. I could remove it because it was very easy to remove it after 8 weeks. It could be removed, put in a plate, and then ultimately the whole excellent range of movement and everything happened. So nail came out because of 4 months and a good shoulder movement. And enough nail was out for 6 months. And still what we talk about a cuff injury, it has not happened. This is another case, same situation.
Sir, just a minute. The last plating case.
Back.
One before. This doesn't look like your plate, sir.
क्यों भाई क्या हो गया?
छोटा है प्लेट।
25 साल पहले कम से कम 8 होल का प्लेट और 4 लगता था, ये 6 होल 7
ये है ना 8 होल तो है ये।
8 होल है 8 होल है
2 होल इस इधर नहीं लगाया। You can see the gap. 6 होल का प्लेट तो जिंदगी में वापरा नहीं हम।
Sir, in between there is a one question from Dr. Dhaval Desai.
If you do the same patient, you will not do it today like this.
Possibly I'll do a
वो
longer plate.
लोग आपको कॉपी करता है सर।
नहीं हम थोड़ा लॉन्गर प्लेट करेगा।
हाँ, लॉन्गर करेगा और स्मूथ भी स्पेस आउट होएगा और वो देखता है तन्ना साहब ने ऐसा किया, वो इसको नॉन यूनियन में भेज देगा।
हाँ, so क्या बोलता है धवल? What is he saying?
No, he is asking from the previous case. In long term, does the fibula persist and does it pose a challenge in the future revision? Your experience, sir.
You mean
fibula grafting?
Intramedullary fibula.
Interfibula, yeah. Even in the humerus or yeah.
I have done the total hips in the neck of the femur. It is a little difficult to make a passage, but then you always can manage it. It's never that you have not been able to manage. It is difficult. I agree.
Okay, sir.
Here is the same thing. Now here is the Indian jugaad. Nailing which is done for this is not an ideal site to do the nailing. There is hardly any nail distally. So it has been supplemented with this sort of a splint. Or again, this is another patient. You can see another splint. This was one splint. This was another splint. Same sort of a non-union. Asim ये अभी का है.
Yes, sir.
Asim, this
ग्राफ
is the
भी
plate.
ग्राफ भी किया होगा उसको.
Yeah, अब तो सब कुछ करेगा ना.
हाँ, सब करेंगे.
And you can see I put in a long plate, 3 screws, nothing in between.
Yes, absolutely.
वो सर वो आप कुछ भी करो जुड़ जाता है आपका.
Now here is the case.
Sir, do you use a Buller's compression device to achieve compression?
I think I always use, you know it.
Then in humerus, femur and tibia, nobody is debating.
No.
In humerus, sometimes there is not enough space on either of the front.
If I realize that 1 or 2 screws compression, if it does not go into compress, then I use a Muller device.
Okay.
But I also now, once you're saying, I want to say the Indian DCP plates.
Yeah.
So many
Yes, sir.
times with the holes, it does not unite. I mean, it doesn't give you a compression because they're manufacturing that holes which is made oval holes. It doesn't give you the compression so many times. So in an Indian plate, if you see there is no compression, I feel you should change over to the Muller plate or Muller device or a device with the Weber device with the compression there. Because otherwise the compression is the main part of this healing process. Now here it is again the same. Transverse fracture, nailing is the one which gives rise to more problems. So this was the one which was removed by this sort of a jugaad by me. I put in a hole here, right there, put in this curved wire and pushed it out at the fracture where it has come out. And this is how it has come out. And then I again went out. Here is a 4th surgery, 5 years post-op. अभी क्या करेगा? Fibula. We have discussed this.
Fibula.
This is exactly, this was 5 years, all these broken down things and all. So I went and hit the fibula, hit the grafting. In 8 months' time, it is healed up. Now, if I ask here, Asim, तेरे को पूछेगा. When you want to do the compression after the fibula, how will you do the compression?
We have to overrim. We have to
overrim रहता है ना सर, वो तो slide होता है. अभी तो दिखाया आपने. दोनों तरफ
fibula should be loose inside the medullary canal on both the sides.
And you should not screw with the fibula. You have to go far away because if you take the fibula inside the bite with the screw where we're compressing, it will not work, sir.
So when you want to compress this, you have to pass the one screw here and the other screw here, and then only you will be able to compress.
Then only, yeah.
If you put a screw here, then it's here, that will not work. You will have to be at least onto this side. Even if on one side the screw goes through the fibula, but if the other side, if it is outside the fibula, it may still work.
Yeah.
So this is healed up in 15 months time. All these are the recent plating which you done. This is another 22 years old struggle. I think this is the same case probably. Yeah, it's the same case.
Yes, same case has come.
So in conclusion, nailing good isthmus, snugly fitting 2 inches on either side of the transverse fracture, 3 nailing dynamic for 400 nail and 380 nail in a dynamic mode in the isthmus only again. Construct is not stable after nailing. Make the stable by multi-directional locking screws or either side, leg screws or an adjuvant, not the leg screw, the quarter screw or an adjuvant plate. Non-union, treat aggressively by all the gadgetries, whatever you have. It is a non-union is like an extreme sports. You must do it in the everything possible with all the precautions. Then only you must go ahead and do the non-union. Now you can present your cases. Dr. Sangeet, you can start your case.
I already presented one case, so
Still there will be enough time because we know
Yeah.
that
If
I don't have to finish everything.
yeah.
All of you present two cases. Because
Jignesh bhai,
ultimately it is the same
Jignesh,
purpose is served.
Jignesh bhai, you are not allowed multi-sharing. Allow multi-sharing so that overlapping can be done.
Sangeet, are you sharing?
Sir,
No,
done.
sir has to stop share.
Yeah,
Sir,
that is the
sir,
issue here. He has not given an option of multi-sharing. If you
sir,
give
I
a
started.
started, okay, fine. Now you will be able to. Sangeet bhai.
Dr. Khanna, you have to, sir, stop sharing.
Yeah.
हमारा तो वो चला ही गया शेयरिंग वाला कैसा आएगा
हाँ तो हाँ
Yeah.
चला गया
Minimize करो sir उसको.
Now you
बस
can
ये
share.
आया
हो गया हो गया
हो गया
हो
हो गया.
गया ना
हाँ.
चलो
Now the panelist can share. Yeah.
Yeah.
Dr. Sangeet, yes.
Yeah, that was not given previously.
ठीक है सर. फुल स्क्रीन सर. हाँ आ गया.
ना वो कर देंगे. All are seasoned खिलाड़ीस.
ऑल सीजन है सबको सब मालूम है.
Thank you.
बहुत each one of them have done innumerable webinars.
Yes sir. Thank you.
ये पहला स्लाइड है संगीत.
Yes, sir. So,
यार आप लोअर मत लिखो, हमको डर लग रहा है लोअर लिख रहे हो.
That's a very important information.
the purpose of showing this case is the intro of difficulties. Like if you are alone and if you are not sharing the case with some other surgeon or you don't have a competent assistant, like what difficulties you can face. First is the diagnosis here. Now, this gentleman was a high profile lawyer. He had uncontrolled diabetes, doesn't listen to anybody, and he has undergone multiple surgeries in past 10 years. The last surgery
for the same fracture.
For the same fracture, for this problem. And the last surgery done was about 5 years back. Now, he landed up with a 3 months pain in the knee joint, very specific. No pain at the non-union side, no pain in the hip side. So, so now this is his AP and lateral view. Now, the fracture, probably it has healed, not healed, it is in a hypertrophic non-union, or probably he doesn't have any pain. And he has been walking on this for 5 years. See, only concern is the angular deformity at the knee and the nail which has protruded beyond the Blumenset line. That means probably it is in the intercondylar notch. And this valgus angle of the distal femur. And third possibility was, are there any OA changes? But his joint looks fairly good enough. It is not that bad for the age of 70. Now, this is the magnified view of the non-union. And knees, where he has pain, where he has come to us for, there is nothing seen in the knee. So any one of the faculty can pick up what is wrong with this knee. Is that the cause of his pain, source of his pain? And what surgery I offer him? High profile lawyer. Yeah, Asim.
Sangeet, I will do all the necessary ESR, CRP and all those things.
Is ruled out. We are talking of aseptic non-union.
Yeah.
So,
I will do a Mars MRI also. Money is absolutely no concern. High profile lawyer, Mars MRI to know more about the knee and any other problem relevant to his symptoms, because you are again and again saying that he has got pain over the knee joint area and not over the non-union. And having played it safe that, okay, there is nothing seriously wrong intra-articular with the knee. He needs correction of hypertrophic non-union. All those axes have to be corrected. Shingling and bone graft, plenty of bone graft.
You said non-union. Is it established? You say you're
suspecting. It is non-union, pakka.
The words
this axis has to be corrected.
I have to be very careful with the words what I'm using.
Yeah. No, I think it's not united. Sometimes on table also, if you open it, it's not sort of mobile. You have to literally take osteotome and shingle it out, and then you know that it's not united.
I have drawn, sir. I have drawn, sir. Probably you need a CT scan, and you may have to know there may be a crack itself in the nail also. Possibility.
Nail also, yeah.
Gadigone, sir?
It's not united.
He has gone. Probably
No,
he
no,
has
no, no. I'm here. I'm here.
Okay, okay.
It is because of Navin Bhai said there must be some crack in the fracture side, which is creating a instability and axial loading, which is on more medial side. Therefore, he is getting pain. Whenever there is a instability in the fracture shaft of the femur, majority patient they get pain in the knee joint. It's because of instability. So you can see here there is osteolysis here in the nail. You can see in the tip there is some osteolysis. Means if you do a CT scan, probably you will be able to rule out the non-union as well as some crack in the nail.
Sir, axial loading will be higher on the lateral side in this. There is 15 degree of valgus at least.
Yes, whatever it may be.
Yeah, lateral side. Yeah.
To all of you, how many times you are doing a CT scan and how many times it has been helpful to you in changing the decisions?
It doesn't change the decision, but I do it.
Is it useful?
Yeah, it is useful. It is useful. It is useful. Here the nail is going almost posterior in the posterior part. So there is a continuous loading at the fracture site, slight angulation. So there is a possibility always, if there is a nail is broken, I have to be ready with the removal of the nail problem area also. So that has to be taken care of in a preparation. So I will be ready with the plan A, plan B, plan C. All the plans I must be ready. Otherwise, there will be a problem at the time of the surgery. So for that, I must have a CT scan to rule out, is there a smallest crack in the nail itself? That is the possibility. And non-union, it looks, it will be non-union. That is correct. You will be ready with another nail or a plate or a bone graft. Everything will be ready. But many times we do not think about the breakage of this implant and difficulty in removal. That is the first part.
Sangeet, we are here in dilemma. To clear that dilemma, we are doing a CT scan. Otherwise, majority of the cases, CT scan is not mandatory.
Yeah, yeah.
And you have written a big letter, lawyer.
Yeah. So probably
Sangeet, may I add? Many times in a difficult situation, I send the patient for CT scan so that I get 2 days to talk to Sangeet and Dr. Tanna and Gadigone Saab and Naveen Bhai and everybody.
And
so we know what when he comes next day.
And
we got our plan ready. Yeah.
And another issue is there is a fixation on the both the side, knee side and upper side. So there are all chances of point loading at the fracture side when it is not united with the key nail only.
Right. Move.
So out of this discussion, 2 important points: CT scan for the non-union and CT scan to see whether the implant has broken and what has happened inside the knee joint. Right. So, so what would be the surgery? I have to tell him. He says very clearly, you solve only my problem in the knee joint. Okay. So what do I offer him? Only implant removal or exchange nailing and give us stability because it is already hypertrophic type of non-union, or the reaming products are good enough and I can add bone marrow aspirate what you have suggested. And do I have to open the non-union formally like any other non-union and treat it as a non-union? So these are the options. So what would be your choice in this case? Now, what you can see here, the eye of the nail, this is a Kuncher nail. It is below the tip of the trochanter, right? And there are broken drill bits and the part of the previous surgery, these are screws. And plus there was another drill bit here on the medial side.
Yeah.
So
also you have to think about the low grade infection also. One more point, because of these drill bits are not the implants, so there will be a chances of low grade infection also, or a reaction around that, something like that.
Right. So
5 years have gone, and in 5 years' time, there is an infection is going on,
Yes.
and he is very comfortable except the knee pain, it's little difficult to accept that.
But very
In
low
any
grade
case-
infection can remain, sir.
Yeah, fine, fair enough.
So the
And
blood
here
parameter.
your question, Sangeet,
Yes.
only exchange nail,
None.
it is only you are trying to only ask a menu card.
No, sir.
I'm
As a
sure
surgeon,
you are going to do everything.
Go for the
as a
overkill.
surgeon, I'm giving you as a surgeon, like you're in dilemma where mobility is, it is not a clear cut non-union. Even the X-rays, it is doubtful. Probably if you magnify it, then it is.
Are you genuinely convinced that there is no non-union?
I'll come to it. I'll come to it.
Because I think this is a hypertrophic. You've shown a magnified view, which
Good
shows a
magnified.
definite 5 years ke baad maybe fracture line is seen, which if it is healed up, it would be obliterated completely.
Sir, that magnification, I did it now.
I thought we
Time
will
of
do it.
surgery, I have not
In
done
any
it.
case, we will do it earlier.
For magnification, we were requiring CT scan.
Anyway, chalo, aage chalo.
So the plan was like, I had told him it is a non-union, and the entry was for the retrograde nail. So I pushed the K nail higher up, and then I took it out, and so I checked the mobility after that.
Mobility. तुम बताया, demonstrate किया है mobility. है ना?
Video is running very slow. It's running.
है.
So it is not a frank mobility on one
Hey,
side.
hey, Sangeet. Hey, Sangeet. इसको तुम frank mobility नहीं बोलेगा.
You cannot translate it. That is
Yeah,
what
yeah,
I'm saying.
not
No.
like a fresh fracture, but it is a mobility. Yeah.
And
So you will think this may have united.
no, sir. So
It's a
there is no
hypertrophic
break,
thing. Yeah. Okay, fine.
there is no break on the medial side.
Yeah,
All
yeah.
what we are seeing is probably opening on the lateral side.
Yeah.
But why there are screws and drill bits when it is a K nail has been used? We cannot understand for the K nail why there were screws and drill bits.
Previous surgery.
But
He has undergone
All
previous
plate
surgery.
with the screws must have remained broken screws.
okay.
So all that intramedullary implants were removed, and then I did a retrograde nail. Now, and I opened that non-union, but to find a plane was very difficult, and I digged it up to the nail, but through the corresponding fracture non-union plane, what was seen on the magnified view of the C-arm. But to get that fibrous tissue, some fibrous tissue was seen on the lateral side. I reached up to the implant, but still I was not convinced that it is a fibrous tissue. Probably I was removing more of a new bone at the end of the surgery. I packed that, and probably at the end of the surgery, I felt probably I was creating a fresh, I was opening out that non-union and creating a fresh, something like a fracture or creating a new plane. I could not get that plane. Some fibrous tissue was seen on the lateral side. And finally, this was operated before lockdown. This is his 4 months post-op X-ray. His knee pain has gone. He's walking without a stick. He has a good knee flexion. Now, any opinion on the kind of surgery? The reason is I have not added augmented plate. Probably at this junctional zone, I should have, because this is a hypertrophic type of non-union. The mobility, even though it was the implant, it was quite stable. It was a hypertrophic non-union, and I packed some grafts there, but I was not convinced. How many times we come across such situation? One, and do we
you packed the graft taken from a iliac crest or somewhere?
Iliac crest.
Same one locally.
No, sir, iliac crest.
Okay.
There was there a locking proximally anteroposterior also?
Yeah.
है ना?
Yeah, it is
Two
there.
screws are there. Two screws
No,
are there.
anteroposterior.
Yeah, it is anteroposterior.
Okay.
But
This
then
is a
you
lateral
are not
screw.
seeing them in the
Oh,
APV.
yeah. But there
This
is
is
a
the
one
lateral.
screw distally from medial to lateral interlocking.
No.
In the AP
This,
view, if you
There are
see one
four.
screw is medial to lateral.
this is a multi-lock Smith
Yeah.
and Nephew, which
Yes,
has
with an
three.
FNL. That's why it is a oblique, but it is from medial transverse screw medial to lateral. There is no oblique screw 45 degree.
These are all in three different planes. You can
Yeah,
see the
yeah.
lateral
You
view.
are right, but it doesn't look 45 degree. It looks almost transverse medial to lateral screw. Yeah. Can I mark it?
Yes.
This screw
Uppermost.
uppermost. Yeah.
Yeah.
चलो नवीन भाई है ना उसमें बस हो गया ऑब्लिक है
नहीं वो नेल का कौन सा डिजाइन है वो जानने के लिए पूछा मैंने.
तो बताया ना
It is a
Smith and
Smith and
Nephew.
Nephew.
हाँ समझ
If
गया पर
If you see any of the X-rays, they look like that.
okay.
Okay. So now second thing is like how far proximally you accept a retrograde nail should be pushed.
इतना तो बहुत
Beyond
होगा.
the
इतना तो बहुत होगा.
देखा.
beyond the lesser trochanter. Now, if you have a situation where you have a fracture somewhere around this area, so what
And
should
why
be
do
a
you want to
stigma?
go retrograde? Why not antigrade? If you have a higher fracture, you will go antigrade, no?
Coming to the point, like how far you can go proximally.
the upper screw, if it is gone through the lesser trochanter, it gives a better stability. It's because the purchase of that screw is longer than the diphygeal. Therefore, it is said that the upper screw, if it is going through the lesser trochanter partly, then it gives the best stability in a supracondylar nail.
But he has done both the anteroposterior locking here. He has not done the mediolateral or lateromedial
If
locking.
the nail provided are anterior posterior.
Yes, so
Because
that doesn't come.
in a mediolateral proximally, it's damn difficult to see it in SIA.
Sangin, how difficult is to exactly know the length of the screw in the distal part when there are oblique screws? Many times we think that it's a adequate length, but when we see the X-ray, it becomes longer. And many times we feel that it's a right, but it becomes short.
No,
In
you can
particular,
rotate-
this design.
There is no issue. You can rotate the femur and check.
So in all direction you will see. In one view, it is coming out.
Yeah.
Sanjay, will you have done a beautiful surgery. Will you elaborate how could you correct the axis in a long standing hypertrophic non-union using a retrograde nail, which even in a fresh case is difficult. Even when we are using a plate to correct the axial alignment, it's very difficult. So how could you do this with perfection? Tips?
No.
I
This is
used,
excellent. Yeah.
Right. The issue was there was some opening at the fracture site. So probably I could compensate and accommodate that. And I don't use polar screws. I use polar wires, thick 2.5 mm wires. Yeah, no wires, K wires. And once you pass the guide wire, you get a fair idea how much. And this particular system has 9 mm all. With that, you clearly know whether your nail is going straight or it is touching either the lateral or the medial distal femoral cortex.
And here the nail diameter is almost 11, so that will also align the fragments.
Right.
Once the nail is passed, automatically that will align. That will give some force of the alignment.
So amongst all of you, how many would have added additional augment plate?
Probably no graft. The whatever shingles are there because there's so much of bone. But I would have added the plate. More so because he's an advocate.
And second,
probably
indication for plate is the advocate.
No. Partly orthopedics, and obviously you are under more pressure with these guys.
But it is a good stability. This design is a good stability in multi-plane, so you may not require the plate many times.
And in such type of non-union, second question, in such type of non-union, do we have to really dig the non-union, freshen both the edges, shingle out everything, and then pack the grafts? How many of you would be doing when you have a situation like this? Treat it like a normal non-union.
Sir,
So there is a good balance.
Sangeet
Yes,
sir,
Dr. Gavin. Yes.
in a hypertrophic non-union already there was so much calluses around it. Only it needs the stability. No bone grafting is necessary because that fibrous tissue will go into a osseous tissue. Therefore, unnecessary fiddling that particular area is not mandatory. Best way, compress the fracture by any means and leave it like that. Sir का opinion क्या है?
Yeah, I think this will help because this is a distal femur nail, which is 3-4 screws, and a subchondral it has remained there. So distally it is very stable. Proximally it has gone in the isthmus tight fitting, and 2 screws. I think this will help.
Yes, it will help. But as he is a lawyer, you have to explain that you may need an augmentation plate if it fails or it is failing.
नहीं, वो तो वो you may need बोलता है तो अभी डाल दे, अभी क्यों नहीं डाल? And I'm 100% sure Sangeet would not have waited for that. He would have put in the augmentation plate if he felt it was needed. Yes, no, Sangeet?
So it was quite stable after
That's the
locking.
reason you didn't choose.
That's why,
Yeah,
yeah.
we agree.
And even the grafting, like digging a normal bone and locating the plane of the non-union, I thought it was unnecessary surgery.
Yeah, exactly.
So,
Okay. Now, who is presenting the Asim ki gaadi kone?
Yes.
Bolo gaadi kone?
Yes, sir. So this is a case of a infected non-union segmental fracture of tibia. Now this is not my case, but I have inherited this case. Patient detail 30 years old male, high velocity trauma, left segmental tibial fracture, no associated injury and insignificant past history. He is a healthy man. So treatment option as usual, a multi-lock nail may be infrapatellar or suprapatellar approach as desired by the surgeon. MIPO plate rarely, or you can use Ilizaro or X-fix. So infrapatellar and suprapatellar debate continues. We will not go into the details of it because everybody knows about it. So this was the surgeon choice, operated in 2017 in other facility, and there are so many issues with this. Regular thin nail, multiple polar screw with holes. These are all there. He has tried to do. He must have heard the Turner sir's lecture, and so that he has done this compression here and there, and an inadequate length of the nail. So this is it a day one failure or it will unite? Naveen bhai. Sangeet, am I audible?
Yes, you are audible.
Sangeet sir.
I don't know. Yeah. But I don't know what has happened to other speakers.
देखो थोड़ा सा.
Sir, you can continue. I think they will join back.
अच्छा.
Join back.
So this is the multiple porous hole, inadequate length. So what do you think?
So only two of us are here. Yeah.
Yeah.
So probably the proximal small fragment has only a 1 screw fixation, and already there is a procurvatum deformity. So it is unstable from day one. So the whole issue is the non-union. Probably it is heading for a non-union and instability at the proximal fracture.
Proximal fracture.
Yeah.
So this was it was can we say it is a day one failure, Naveen sir?
Yes. Apex, it is not matching. It is a flexion, slight flexion. So you require an interfragmentary compression or an additional plate there. So you get a stability there. I have a similar.
आप लोग को वार्न करेगा ये आप जादूगर के साथ बात करते हो.
जादूगर से बात करते हैं फिर भी सर there is a oblique fracture and that interfragmentary screw or it's a polar screw there.
Okay.
So this is not done by me. This is
but the polar screw is exactly at the fracture site, not that is not right.
I said he must have heard the Tanna sir's lecture and he did the surgery.
It is not a polar screw, it is an interfrag screw.
Interfrag screw.
Which is not doing anything.
So
because he has tried to do it subcutaneously.
So
probably after the nailing.
After the
nailing, yes, before reduction.
Just to improve the stability or some correction. So presented to
me. He had not heard Gadigune. Then you hold them with the tooth faucet, and then you have a clamp, and then you reduce it,
and also the traction was given heavy, so distal fracture is also in the distraction.
Okay.
He heard only part of the sentence, not a complete sentence.
अभिमन्यु जैसा काम हो गया.
चलो आगे चलो.
Presented to me after 4 months of post-op X-ray on a fever, discharging sinuses, pain and instability to bear weight, prolonged oral antibiotic post-surgery without result, Klebsiella pneumoniae, and what we can offer to this patient: nail removal and debridement, renailing, stage definite, regular antibiotic, cemented, coated. These are all varieties of treatments are available with us. My plan was to remove the nail, reaming, debridement and canal wash, antibiotic-laden cemented interlock nail, culture-specific antibiotic. So infection after intramedullary nail fixation, usually it involves the entire medullary canal. Infection spreads along the length of the nail and involves the entire length of the bone. Infection is primarily intramedullary, and therefore rationally of treatment should be to eradicate the infection from the intramedullary canal by any means. So these are all antibiotic mixed cement coated. They are all available, and it is available in literature also how to do it. So what I did, reaming of the canal, wash with cocktail solution of normal saline, H2O2, and what I do here, this is the reaming. This is not the X-ray of the same patient, but this is the method which I adopt, and then wash everything. So you have to ream it, all debris should be removed, and then irrigate the canal completely. And then
महापात्र सुनता है ना ये अभी ये जो सवाल पूछा था ना उसके
अभी क्वेश्चन नहीं आया सुनते होंगे मगर क्वेश्चन नहीं आया.
Reaming, canal wash, gentamicin plus vancogram mixed with palm, prepared antibiotic cemented rod, and these are the nails are available serrated with Yogeshwar implant. I use it. So use of antibiotic cement included intramedullary nail in the treatment of infected non-UNAP long bones is a well-established method. Antibiotic mixed with palm impregnated nail is the best option and is to be put in after complete polymerization. So these are all benefits, everybody knows about it. There are some demerits and drawbacks also, because high concentration of local antibiotic elution up to 200 times and greater than with systemic drugs. So this is a very good method. It gives a sterility to the canal. So this is the immediate post-op X-ray, correction of malalignment, thicker snugly fitting antibiotic coated nail, vancogram plus 4 gram in, and then 160 milligram of gentamicin in palm. Advice exchange nailing at 6 to 8 weeks. Patient didn't turn up. Gap evident. Here it is there. Ambulatory full weight bearing without support. Denied nail removal after exchange. And then 3 years post-op came for implant removal. So the infection has eradicated completely. Deformity is corrected. The patient is walking about, and then he came for the removal of the nail. So antibiotic coated interlock nailing provides the advantage of definitive fixation and often full weight bearing. So meaning thereby, if you use a thin nail like rust nail, Ender's nail, V nail, on this there is a coating, you get antibiotic rod, but you don't get stability. So the interlock nail can also be converted into an antibiotic rod so that you can lock at the both ends, giving the stability. Cement coated wires, Ender's rod, non-lock nail require partial weight bearing and often requires second stage surgery if the healing is not complete. External fixators are more cumbersome and difficult in weight bearing. So removal of nail is tried in the last week but could not succeed. You can see here I have removed this screw here and here, and I tried my level best for near about 1.5 hours, but I could not. I tried all methods. So is it a osteointegration of palm in the antibiotic coated rod in the medullary diaphysis? That was the question, because whenever you want to remove the rod as early as possible when the union takes place. Otherwise, you face this type of situation where you may endanger of a fracture of the tibia again while removing the lid. So this is the case. Problem of late removal. Early removal is due to the non-healing of the fracture and some mobility. Fracture union creates a stable environment with strong bond, making removal difficult. So infection in orthopedic surgery is a disaster, both for the patient and surgeon. Increases antibiotic use, prolonged hospital stay, repeated debridement, prolonged rehabilitation, morbidity and mortality, higher rate of financial constraint. Antibiotic rods, the use of nail in the treatment of tibial infections due to be a reasonable option, clearing 76% of the infection at 6 months of the time.
Gadigone sir, may
Yes.
I interrupt?
Yes.
What type of nail you have used? It was a ready-made nail or you have prepared the nail?
He prepared.
You have prepared the nail. You have given a serration to the interlock nail,
Yeah,
custom made. Custom made.
custom.
But
Okay.
sir, are you
But
trying to
only-
propagate that as a definitive implant? Because my understanding is it's a temporary situation, control infection, and after a few weeks, 6 weeks or something, you replace it with a regular nail.
That was my.
You are trying to suggest that we can keep it till union and then remove it 8 months and 9 months.
If there is no pain and the fracture started uniting, there is no need of removing the nail. Why to remove unnecessarily when the
That's a side track. So if there are enough cases, then you should talk about it.
एक मिनट गाड़ी को एक मिनट. You have kept the nail inadvertently.
Inadvertently.
You had asked him to come and take out the nail, or you not asked him to come in?
I asked him for exchange nailing,
Full
but
stop,
he,
full stop, full
but
stop.
he
Why
we
पूछ रहा है?
agree, we agree,
बस,
we agree.
we agree.
So whatever Asim is asking,
हाँ.
would you second time do a nail and not remove it?
No. I will remove and do a exchange nailing, whatever
Exactly.
it is possible.
So that is the treatment of choice.
That is the treatment of choice.
Because I think I don't want you, as Asim mentioned, somebody coming from you, people feel कि नहीं ये तो छोड़ दे वो.
जादूगर ने किया है.
The message,
It's not
yes,
like-
message should not be like that. And yeah, and the question is why you selected a short nail when you are doing customization. Distally, there is a still good space in the tibia.
Yes.
And there was also a fracture distally.
Where is the fracture distally? No.
No, there was a fracture. There was a fracture. Net? There were two
Middle
fractures
third.
here.
It
No.
was in middle
It
third.
was a middle third fracture.
No, upper
Gadigone
and middle
sir.
third. But the
It was a
nail,
segmental fracture, no?
it was a segmental fracture. The length of the nail. I am speaking about the length of the nail.
Oh, that I.
There is a fracture
Go back,
just below
go back.
the fibula.
Yeah, go back.
There is a fracture below the fibula. Below the
Yes,
fibula
it is a
fracture.
Yeah,
segmental fracture of the fibula. Segmental
Because you made a customized nail, you could have measured and made a length fully.
Yes.
No, but
Probably,
now
probably.
it is a cemented, really tight fitting nail. So that's why it has worked.
It has
It
worked.
can work, but still.
Agreed.
Yeah.
Yes,
Gadigone
Samir.
sir,
Yes.
second question I have. At
Yes.
what stage of cementation you implant the nail? When it has already consolidated outside you allowed
Endowment.
After
allow-
consolidation outside, after total consolidation outside.
Okay. So when you hammer the nail inside,
Yes.
okay, now the nail is round. So how do you make the cement around it as smooth as a nail? The coating of the cement, it will be uneven.
It is
No,
a,
you will pass through those measures, no ACL guide or the femoral guide. When you pass through that, it becomes absolutely uniform. No?
So, sir, the issue is the nail is stuck now. So we are trying to find out what are the causes why that has happened. So one of them could be that
संगीत उसको chest tube में बनाता है.
नहीं, वो stuck nail is a reality if it is not taken out for a 2 months or 3
Yeah.
months time.
Yeah, yeah.
We all know it very well.
So
There is enough cases. As a senior senile people, I have come to at least 6 people who have been at the nail which is stuck up, and they have come to remove from me. I said, sorry, I can't remove it.
only way is you have to bifid the tibia. Only
Yeah,
way
yeah,
is
yeah.
I have a complete case of bifiding the tibia. Our patient has not turned up, and that's why removal was difficult. So I had to bifid the tibia just because this cement will become a nidus for the next infection also. That
I
is
think-
also a possibility.
I think Dr. Chandok has shown a case for exactly the same thing what you are talking, Naveen, because
Yeah.
it was infected. Now
Yeah.
it was infected. In order to get rid of the infection, he had to do this osteotomy of the femur.
Yeah, yeah.
Osteotomy of the tibia and
Same-
had to take it out. If
same-
there is
same
no,
thing.
no infection, we may forget about it. And if I have at least 2 or 3 cases where the nail came out, but the cement remained inside. And
Yeah.
there is no way you can take it out.
Yes, absolutely right. But here he has made a serration, so it is the good
It
bonding
is
of the
forbidden.
cement and the metal. If he had used on the smooth nail, there was a possibility. Yeah,
If I
I mean,
remember,
I-
Naveen,
I can show you a case where the removal was done by a different surgeon. I had done a very early days on a smooth nail, and the cement remained inside.
exactly.
So Naveen bhai, do you want to conclude that this-
नहीं, Asim has to show the case, not last case. Asim, तुम
No,
नहीं
no.
दिखाया?
About this case, the message he
Sorry,
wants to.
sorry.
Message
So
is
the
that
cement-
as soon as the fracture infection control, do a exchange nailing, and if at all it has united in the same situ, try to remove as early as possible so that the osteointegration of the palm will not occur and you will not have a problem in removing the nail. Is it okay,
so
sir?
you mean to say
Yes, I think
the
yes,
cement-
again.
you
Yes,
mean to
again.
say that cement integrates with the bone if it is not removed beyond 6 weeks, where infection is totally controlled.
Yeah.
Naveen bhai, you said this.
There is a
No, no, no.
possibility. There is a possibility because there,
That
even if you
probably
try
that is
to,
the cause.
even if you try to make it as smooth as possible, still there remains some concretions, and there the bondage occurs between the bone and the cement, and that doesn't break. Even if you use a large hammer, still it doesn't break. So that
in
is a
this case, that is exactly what has happened, you mean to say?
yeah, possibility is this. We have to study multiple examples of like this because we all have a 1-2 cases only.
Naveen, I
Yeah.
think all of us have done a revision here.
Yeah,
And when we remove the cement, it never really integrates with the bone.
yeah, it doesn't integrate.
There is always a space. We create a space and then the whole tube comes out.
Yes,
I think Sangeet and Asim or all of you have
but
done that.
there you are opening, either you are doing osteotomy or,
No, I
or you
understand
are
what you're
making
saying, but-
from the canal and special instruments. Here you cannot go with the special instruments because there is already a nail.
Exactly. I have an objection about the integration. What I am
Tanna
talking
sir.
about, it doesn't bone has an
Bond
integration
नहीं होता है.
with the implant.
Bone.
It doesn't happen here. With the non-cemented implant, there is an integration between the cement and the implant. Between the implant and the bone. It doesn't happen
Sir.
in a cemented one.
Yeah,
Sir, there are two different situations. In a hip, we are putting a hot cement inside the medullary canal. Here, we have put a cold cement, which
Yeah.
is already so
Cured
that
already.
it is
Get
not
outside.
going to integrate. By any chance, it is not going to integrate with the
Yeah,
bone.
it's not going to
Unlike-
integrate. You are right.
no,
You are
it
right.
is not integrating. It is not integrating. It
So
is
I
not
think it is
integrating.
a word objection to
Yes.
the Naveen's
Yeah,
word.
yeah, absolutely,
Integration,
absolutely.
that's all what it is.
But
only possibility, only possibility, it is a porous structure. So while you are hammering, it shrinks, and when you remove the hammering, it may expand little bit and may get stuff fitting. That is the only possibility. That is the only hypothesis.
I have come across with the literature in the dental implants, when they use it with the palm, there is a osteointegration process is involved, because the surface is not smooth, it is a rough surface, serration surface.
The
Therefore,
newborn
the word
formation
is
stuck
correct,
with that.
but it is not described in the literature of orthopedic, that osteointegration. But in the
with all the due respect to the dentist, they describe it whatever, because it is exactly like this. It got stuck, so now it is there. So that's a different thing. You and me know it very well what it, because the bone of the mandible and the bone of the femur is not anything different.
Yeah.
Okay. Same your last case before we proceed. Yes.
So this is how it is. Prevention of infection is better than cure, is the take-home message.
Oh.
साहब आपने पीजी लेक्चर वाली स्लाइड उठा ली है.
चलो
अनशेयर करो सर इसकी. हाँ सर, अनशेयर करेंगे तभी होएगा.
ओके सर.
चलो, last case of the day.
Yes sir.
I have many cases to share about implant, this impregnated rod implant, this rod. There are so many cases.
तेरे पास तो खजाना है, खजाना.
PFN का, I have a PFN case, one of like this. But if the time permits.
I think now we will ask MCure people. Abhi to we have finished only half of what we had done. If they desire, we can do it after some time, the other half.
Next week, next week, part 2.
Okay,
Yes, sir.
Chalo, Asim.
Yes, sir. Here is a 4-year-old baby, fall on an outstage hand, and she was treated outside somewhere in Rajasthan with, this was the day 1 X-ray. Surgeon gave a plaster. Then he was told that he should do an X-ray at day 10 also. So he got this X-ray done, and he still continued to conserve. We proceed.
Typically pediatric orthopedic surgeon asks for arthrography at that time, or MR, to know the exactly where the crack is going till on the medial side. So it is a stable or unstable variety.
Yeah. Do you do the arthrography, Naveen bhai?
Yes,
Sangeet?
I do.
Sangeet bhai?
But it is very rarely required.
But this is a clear lateral condyle.
Yeah, lateral condyle.
Yeah, it's opening up. On day 1, probably not, but now it's opening up.
Now it is opening up. That's why MR will save you. MR will save you.
I think if, sorry, sorry, Sangeet, you were going to say something.
So in a setup where we are working for a diagnostic, doing a orthography, probably if preoperative, that may add up to the plan. But like as Naveen Bhai said,
I told about when you are suspecting such a lesion, when you are not confirming that where the fracture line is going. If the fracture line is going medially, then it is an unstable variety. Then you have to pin it, open up and pin it. If it is undisplaced, to differentiate between the undisplaced and displaced.
His question was, will you do orthography now? Or
now it's not required.
Not now.
Now
it is
how
evident.
many people do it?
Now it is evident.
No.
Yeah,
no.
But at least we must do an internal oblique X-ray.
Yeah, I think having heard those pediatricians many times, they talk about it here, that if the MRI or the arthrogram shows a complete fracture, then you need the fixation. If MRI doesn't show the complete fracture, then you can conserve it. And when I had asked them, when there is a doubt, what do you do? He says, no, if there is a doubt, you do the arthrogram, because the MRI is probably may not be as as diagnostic as an arthrogram, because he says we can really inform better with the arthrogram. So if there is a thing which is going inside, they will do the fixation primarily. Otherwise, they have the very, particularly for this level, they have quite a lot of controversy which is going on. But they all agree that if you can prove that it is a complete fracture, as Dr. Thakkar mentioned, is going on the medial side also, then you got to operate on it.
Yeah, fix it. Yeah.
Now, anyway, it is not operated. Now it is gone into non-union.
3 months. Gatigone sir, what will you do at this stage?
I will open it, do it refreshing and K-wire fixation.
You will open up the joint even at 3 months?
Yes.
Or we will accept
because
it?
this needs anatomical reduction here. You can see here there is a gap. So if you don't do it, what will happen? You will have a non-union and a throughout life problem. So to avoid throughout life problem, you have to do it 3 months also. I will open it, do a open reduction, perfect anatomical restoration, and probably function. There may be some limitation of movement.
But
the only problem is
avian.
3 months. 3 months is a fairly long time. So you will have to almost detach this fragment completely in order to realign it. And as he says, the avian is almost a certainty.
It's a nightmare.
It is almost a certainty. But still, with the avian, if the whole alignment is maintained and everything comes back to normal, still the elbow may be better than otherwise.
Sir. May I add? Sir. Hello.
Yes, go ahead.
नहीं मेरा आवाज आ रहा है कि नहीं?
नहीं आ रहा है सही आ रहा है.
Yeah, it needs only in situ compression with a screw. That is the what literature says, and
yes,
I showed it to one of the pediatric conferences. They all pundits agreed, and literature also agrees. This needs a compression screw. Don't try to open up.
Okay, no
Achieve union. Yeah.
Because when you open it up, it almost comes in your hand.
Yeah. So another 3 years have passed now. There is a progressively increasing valgus, there is instability, and there is ulnar clawing. Child is now 7 years. And this is the stress view.
Tardy ulnar nerve palsy has started. Okay.
Yeah, and she has a significant palsy, and this is very unstable. The moment she tries to lift something, the whole elbow just buckles. She can't even play. What will you do now?
In situ fusion. Bone grafting in situ fusion. And
नहीं चलेगा साहब.
And correction of, 1 minute, सुनो तो सही साहब, सुनो तो सही.
जी साहब.
Correction of the deformity, in situ fusion of the bone and the ulnar decompression.
Everything, all together.
Everything.
Yeah. This is the problem. The non-union with deformity, if it's asymptomatic, you can wait and watch. Ulnar nerve symptoms, only anti-transposition. Cosmetic concerns, corrective osteotomy can be offered, but range of motion can reduce. You have to warn and be very choosy in offering the corrective osteotomy for cosmetic reasons. This was a paper which talked about 2-stage corrections. And this is the paper which came in 2006. I treated this patient in 2002. 8 patients, long-standing non-union, significant valgus, everything.
सुना संगीत साहब, सुना थी वो तो ये सब आर्टिकल आया उसके पहले किया. All united. So this is the surgery which is done. Fibrous tissue is removed at the outer border, metaphyseal condyle and the distal humeral metaphysis. You don't try to do anything intra-articular. Achieve compression at the fracture site with a screw. Avoid intra-articular dissection. Accept little malalignment at the level of joint, then this risking osteonecrosis. Place some iliac crest graft, and you choose that osteotomy of the type which is required. Which one is required, that X-ray will tell you. If it's a mesh type 1, where trochlea is not involved, then there will only be angular deformity and you can do an open wedge type of thing, or some sort of only wedge osteotomy. But if the trochlear ridge also is involved, as happens in mesh type 2, then you need a osteotomy which can allow you to translate and bring the forearm in line with the arm. So we did a dome osteotomy
plating, fusion of the lateral condyle and anterior transposition of the nerve. This is her 4 years follow-up. This is her function at 4 years. This is her 10 years follow-up. And this is now, she's 17 years down the line, absolutely normal angles. And this is her function.
Very good, very good.
ये है ना दूसरा जादूगर ये.
I showed it to pediatric surgeons, so two of them, Mandar and I forgot his name. They said that this gives a thought. I told them that when I operated at 1 year, I wasn't really very happy. She had little less correction. She was almost neutral, 0 degree. But as she grew up, because we had fused the lateral side, now she has become absolutely normal, both the sides. So if we had done the correction that day, whether she will have 10 degree of extra valgus now? And Mandar said that next time I do it, at that age, I'll do slight little under correction so that as she grows up, I'll keep this, factor this in. It's a important point that you don't fully correct it. Don't achieve 7 degree valgus. Yeah.
So the carrying angle will continue.
So normal carrying angle can be expected.
Yeah.
If you restore that day, she will have access now.
Yeah.
Lovely.
Because she was only 7.
Any questions, Naveen, from the audience?
Only thing there was a question. What was the range of motion this time, Dr. Nitin from Nagpur?
वो तो बता तो दिया उसने.
Full था ना. She is normal.
उसी टाइम जब आपने स्टार्ट किया सर्जरी,
उस टाइम मूवमेंट जो होता है वो नॉन यूनियन साइड पे होता है. जैसे ही वो कुछ भी उठाती थी.
No, now he has written excellent result. Okay. And Dr. Nitin has written, and Dr. Nitin has asked 2 questions for the previous case of Dr. Gadegone.
Yeah.
Does the titanium nail has any difference than the SS nail for this integration part, and whether you have used the injection gentamicin liquid or a powder gentamicin was used?
No liquid, only powder.
I know. Liquid cannot be used with the cement, right?
Sir,
No liquid.
There is a comment from one of the viewer to Tanna sir.
Yeah.
I will read it. Very, very good webinar. Enjoyed hearing all starwards and मजा आ गया. लेकिन सभी लोग हमारे इलिजारो से क्यों परहेज रखते हैं, इसका हमें टन्ना सर से आंसर.
नहीं है परहेज नहीं है.
We can manage without Alizarov, and that's the reason we are managing without Alizarov. If we need Alizarov, we will not feel shy of doing an Alizarov. In all these cases which is there, everybody has done without Alizarov, everything is a wonderful job. So Alizarov, as I said it again and again, is indicated only when there is no other treatment which is going to be useful.
Yes. I always say in my city, then whenever I will not be able to manage, I will send you.
Okay, friends, I think we have follow anything, somebody. Anybody want to say
आप
anything?
उसको गोल कैसे बनाता है नेल को? आप नेल का जो एंटीबायोटिक कोटेड नेल बनाता है तो उसको गोलाई कैसे मेंटेन करता है? यूज अ चेस्ट ट्यूब. व्हाट डू यू डू?
नहीं, हाथ से करो ना. तुम कुम्हार के पास जाओ. कुम्हार के पास जाओ. कुम्हार के पास. और कुम्हार कैसे?
प्लास्टिक.
कुम्हार मालूम है ना?
कुम्हार वो असीम ने किधर कुम्हार को देखा है यार? तो तेरा चंद्रपुर में दिखता है सर.
Yes. I can show you the video later on. You can roll on the plastic and you will get it completely.
Chest tube you can use.
But chest tube is only a problem. Chest tube is a problem. You have to make exactly the same size nail. And I do a graduated size nail. In the proximal part, I put a more cement. In the distal part, put a less cement. So because the proximal is the canal is bigger.
Very smart. Yeah.
कभी चांस मिला तो एंटीबायोटिक राट की कहानियां बताएंगे. बहुत कहानियां
हैं. Right.
Okay, friends.
Thank you very much, sir. Highly obliged.
Anything you want to say, Dr. Ketan?
Yes, sir.
He has to complete, right, sir?
So sir,
पहले आपको एक चीज बता दे रहे हैं. ये हमारा लोग का आधा हुआ. 1 घंटा 45 मिनट. 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 1 At the pace which we were going, हमारा लोग का आधा हुआ. Plating के बाद में क्या होता है वो तो बाकी रह गया. In any case, if you desire, if you want to do it, we all can do it after about a week or so.
Sure, sir. Sure, sir.
Anyway, you decide all your
Sure.
all the logistics, whatever you want to do it.
Yes, sure, sir.
Okay, please wind up.
अभी story बाकी है दोस्त.
Story बाकी है दोस्त.
Picture बाकी है अभी.
Picture बाकी है, yeah. So I'll just give a vote of thanks in 2 minutes. Yeah. So today evening, the webinar on non-union fracture was very comprehensive, and we received many appreciating comments from the delegates. Many participants witnessed this program across India. We extend our deep gratitude towards the esteemed faculty for this program who made very interesting scientific discussion. Thank you, Dr. D.D. Tanna sir, Dr. Sangeet Gawale, Dr. Gadegone sir, Dr. Asim Negi sir, and Dr. Naveen Thakkar sir. Thakkar sir, thank you very much for moderating these questions. I assure that we at MCure will be very happy to collaborate in such activities. Thank you, good evening, and have a great time ahead. Thank you very much.
Thank you. Thank you.
Can you disconnect? Can you disconnect from the FaceTime and the YouTube?
Yes, I stopped streaming.
So now we are all just
1 minute, sir, Satish sir, क्या मैं भी stop